public hearing of the Standing Committee on Health, Aged Care and Disability inquiry into the health impacts of alcohol and other drugs in Australia. I'd like to acknowledge the traditional custodians of the lands from which we meet today and pay my respects to their ancestors and elders past, present and emerging. I extend this respect to all Aboriginal or Torres Strait Islander peoples and their cultural and spiritual connections to Australia's lands and waters. Today's evidence may include material that some people may find distressing. We encourage everyone present and those listening online to prioritise their well-being and seek support if needed. In accordance with the Committee's resolution of the 21st of August 2025, this hearing will be broadcast on the Parliament's website and the proof and official transcripts of the proceedings will be published on the inquiry website. I remind members of the media of the need to fairly and accurately report the proceedings of the Committee. I remind all stakeholders who are present before us in ensuring the safety and privacy of individuals during these proceedings. This includes avoiding the use of names identifying or identifying details when referring to other parties, particularly children, and ensure that any discussion is respectful, appropriate and consistent with our shared responsibility to maintain a safe environment. I'd like to invite members of the Committee to introduce themselves.
Sam Birrell, Federal Member for Nichols, Shadow Assistant Minister for Agriculture and Regional Education.
Mike Freelander, Member for Macarthur and out of southwestern Sydney and Chair of the Committee.
Alice Jordan-Baird, Member for Gorton, Melbourne's Western Suburbs.
Hayley France, Member for Dixon in Queensland.
Good. Now I'd like to introduce representatives of the Goldfields Rehabilitation Services to give evidence to us today. Hello.
Good morning.
Morning. Good morning. How are you?
Yeah, not too bad.
Good. Thank you for appearing before us today. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
My name is Jane Fajardo and I'm the CEO of the Goldfields Rehabilitation Service.
Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement before we proceed to discussion. So if you'd like to make a brief opening statement, that would be great. Thank you.
Yep. To the Chair and members of the committee, I thank you for the invitation to speak today. I appear before the committee as requested to provide information on behalf of the Goldfields Rehabilitation Service, which is located in Kalgoorlie, in relation to the provision of alcohol and other drug treatment service in the Goldfields Esperance region. Across the region, we continue to operate under challenges, with many individuals and families facing barriers to timely and appropriate care. These challenges are compounded by co-occurring mental health conditions, social disadvantage in geographic locations, particularly in the regional and the remote communities. As an alcohol and drug treatment service, we have seen firsthand that a holistic and integrated model of care delivers stronger and more sustainable outcomes for our clients. The Goldfields Rehab provides a combined service models that includes residential, low medical detox, a rehabilitation treatment program, a transitional housing accommodation support, and a structured outreach follow-up service, which enable us to have a continuum care of, that responds to complex and varied needs. We have a multidisciplinary team with medical and clinical, which is allow us to engage more with clients and address intersecting social and health issues, particularly addiction and mental health challenges that coexist. And we also have strengthened some of the and break some barriers in relation to doing outreach program, which is one of the requests of this hearing today, is the outreach program that has expanded to include a mobile outreach recovery program. And this initiative, we have found, We still have some challenges, but we have found that this initiative supports clients who are preparing for those preparing for detox and rehabilitation, involving the families in the planning and ensuring client safety, especially for those long-term substance dependents. And also we adopted one of the program is a capacity to respond to 24-48 hours, which is critical in terms of the client engagement. So from our perspective, the greatest challenge remains the gap between needs and access. And we believe and continue to adopt a person-centered, trauma-informed. We therefore welcome this inquiry and the opportunity to contribute our experience. We hope that the committee's work will help strengthen the treatment system that is equitable, responsive, and capable of meeting the diverse needs of individuals, families, and communities across Australia. Thank you very much.
Thank you. We'll start with some questions. I might just ask you briefly if you can outline how the mobile recovery program works and how people get referred to you.
Yeah, the mobile recovery program is basically an additional program for our outreach pathway to ensure that all clients who's been referred to to the rehab are assisted. So we send staff to go to the communities. We have a medical, we've got nurse and a counsellor to go to the communities and meet with the client and the family to ensure that they are ready, whatever support they needed, and also give them the opportunity to make their own plans. And then we do a lot of planning and transporting them from the community to the rehab and other kind of assistance that they needed. If they need some support with their housing, some medical support as they go through, while at home they're going through some withdrawals and something that we can help.
So you can do at-home withdrawal programs?
We don't do home detox withdrawals, but we do support them in terms of getting them ready for the rehab and detox, because we do have the detox facility that we can bring them to the facility. Yeah.
Thanks. We've just been joined by Monique Ryan, the member for Kooyong, Deputy Chair. So is follow-up a problem? It must be difficult with you're covering such a huge area from Esperance to Kalgoorlie.
It is very challenging, especially with the locations, but we find it really good with the existence of the outreach. The detox facility is also a significant program, because that is where the clients has been assessed thoroughly, and it is important to have the outreach, because sometimes we need to transport them, pick them up, help their families as well. So it has its challenges, but I think the mobile outreach and strengthening that day after day is very essential, and we're getting some successes as well. In order to, it takes some time to get them ready, but it's the visit, it's the introducing what is a rehabilitation service, what happens in the detox, what is their expectations, and the preparations that they needed. It strengthens more their engagement to our program.
Okay. And just one final question from me. How much of your work is alcohol related and how much other drugs? I think these are mixed use.
The alcohol and other drugs, sometimes it's hard to get them separated.
Right.
In terms of in their assessment and their disclosure. So normally in their assessment and all that, while they're going through perhaps withdrawals and going through a lot of mental health or any other things, they would have mixed. Most of them would say alcohol, methamphetamine, cocaine, all that, and even prescribed medications as well. So it is basically it's a mix of use, but definitely there's a rise in methamphetamine.
Sorry, just say that last bit again.
There's a rise in the methamphetamine use.
Right. Good. Thank you. Ali, would you?
Yes, thank you so much for appearing before us today. We've heard in previous evidence that some services have exclusion criteria. Do you have exclusion criteria, or is there do you have to turn people away at certain times because of a lack of resources, or could you just talk us through how you assess who comes into the program and whether you can't provide, services to everyone, and for what reasons?
Yeah. When the client is referred to us, which is a very important pathway, we do, within 24-48 hours, we do our assessment, regardless who comes to any referrals. Probably the referrals is just contemplating to come to rehab, or probably they just want outreach support and all that, but we take them in. All referrals come to our door, and we do we do assessment, book them for an assessment within 24-48 hours. And after the assessment, so a counsellor will do a comprehensive assessment. In terms of eligibility and all that, we've got priorities as well, but it is an internal, especially if the client is pregnant. So we've got some priorities, but in saying that as well, if most of our clients is referred to us, we look at they are deemed eligible for the rehab. If they are some reason they have an acute mental health, like diagnosis, because that is the most crucial kind of findings in any assessment. We have a detox. In as much as it's only a low medical detox, we don't accept any acute mental health, any kind of chronic mental health. We tried our hardest to, we have partnered with the hospital through the emergency department, so we send it to them. We reserve the bed for the client, and also, we provide support while they're in the hospital. So that is one way that any kind of, we do we do have some kind of exclusion as well, but we tried to kind of break that exclusion in a way. We're saying we can't take any active mental health, acute mental health, but we do try to, through the partnership with the hospital. And the other thing, if they have any criminal offences, because most of that comes to our door with long-term dependency, or there are a lot of offences. So these are some of the situations that I think are the bias, and I think are some of the exclusion of we don't take any those who have serious offences like assaults, violence, and all that, because it gives it is for the safety of our clients and the staff. But in saying that as well, we look into other ways to kind of get more information, criminal history, getting other agency who's dealing with them. It's more of the case management. So we try to break the exclusions, in as much as I would say we do have some exclusions as well. I hope I answered your question.
No, that's great. Chair, can I have one follow-up question? Is that all right? Thank you. So in referring somebody with acute mental health issues back to the hospital, does the hospital require them to be detoxed? Does the hospital require them to be... do you have any insight into what happens to them when they're referred back to the hospital, whether they're admitted or whether they get help?
I can't. I can't. I don't think I have the information in regards to what they do in the hospital, but when we received a referral, so if it's a walk-in into the hospital with acute mental health, then they refer to us. After the high withdrawals or detoxification that they do, they will refer to us and we give beds. So sometimes we go there and do our assessment in the hospital, and we take them as soon as we can, because we do have our doctor as well in the detox.
Yeah.
And we have a full-time nurses in the detox, and that's the good thing with the holistic, is that you do have all the resources already that we needed. So it helps. We supervise 24 hours. So they referred to us and they just give us some discharge and all that. And then if there is a flare-up in their mental health, we refer them back to the hospital. So it is more of the safety and how we can, help the clients. And also, if we are the one who referred to the hospital, we support the clients.
Thank you for that.
Thank you. I think I'm next. Hi, thanks so much for appearing before our committee today. Just picking up on the referral sort of discussion, where else do you get your referrals from? Do you get them from the courts as well, or police, as well as from the community, or?
It comes from different avenue, and anyone can refer to us. Even the prison, we get a lot of prison referrals as well, but we only have 18 beds, 18 beds, bed capacity in our rehab, and we have 4 beds capacity in the detox, but we kind of have a better structure in how we can allocate beds. So we get a lot of different from external agency, from hospital. Most of them are self-referred, I may say, which is I think a very good thing.
Yeah, great, thank you. My just second question, if I may, is what kind of trends are you seeing in AOD use in the people that your service supports, and in particular young people? Are you seeing any changes in what you're seeing over the years?
I've been in the Goldfields rehab for at least 15 years, and our service provides, our target group is 18 and above. So at this stage, the average, the cohort, the average age, probably 20 to 30. That's the average age. And over the years, I think there's some development and a lot of changes in our process, and it includes, more opportunity for clients, more engagement from clients. So we started only with a 4-bedroom residential, and then in 2016 we upgraded. There was a big development. The existence of a detox in the rehab, And then we do have 2 transitioning house that they can stay for at least a year. And then we've got the outreach. So these developments has changed a lot for us, especially in responding to those barriers and break down those barriers and all that. So there's a lot in terms of capacity, in terms of having multidisciplinary staff. Professionals are very important, and also the timely response, because we do have, the appropriate staffing, especially if you respond within 24 hours upon receiving. It creates a big kind of change, good change for the client. So I think over the years we have evolved as well. The clients, we had more successes in terms of graduating from the program. So we're happy with, after 13 weeks they graduate, they go to a transitioning house, and some of them has good success stories. They found work, and we continue because they tell their stories in a holistic way from start to until they're with their family. So even in transitioning house, we support them as well. So I think over the years, they are empowered to make some changes. I may say that not full recovery and all that, but I think those steps, graduating, going back to the families, getting some work, and getting their own homes are some of the good things that happen to our client. And all these changes are because of the developments that we had.
That's great. And are you seeing a change in the type of drug use and alcohol use within those cohorts? So you sort of mentioned before an increase in methamphetamines. Is there anything else that you'd like to comment on that you've seen with your clients?
Maybe just in terms of, in terms of their disclosure of their use, it takes time. And I think the most that we note of, the important thing that we note of is that they're very open to, it's more on the what causes them to have, the reason why they're in that situation. But a lot of them are, with mental health, and a lot of, sometimes it's just more on the undiagnosed mental health, or sometimes it's not much of education maybe, and just the historical kind of story for the clients from childhood that was not being treated or not getting much help from the time that they started very early. But in terms of drugs use, I think they're all very the common ones, which is alcohol and methamphetamine.
Mm-hmm. Thank you.
Monique, would you like?
Thank you. Apologies for being late this morning. I think you mentioned that you see a clientele that's aged 18 and above. Is that right?
Yeah.
What services are available to younger people, children and adolescents with drug and alcohol issues in your community?
My understanding is there is a youth rehab in Esperance. We call it the Teen Challenge. I think they provide rehabilitation, but more on as far as I know, is education. But other than that, I'm not aware of any other youth facility, a rehabilitation, a detox and rehabilitation. But in saying that, over the 6 years, GRSI, the Goldfields Rehab, we are in terms of applying for a residential facility for young people as well, because we saw a lot of need, especially in the Goldfields Esperance region, to address the alcohol and drugs for young people as well. So we're on that stage of our expansion as well. We started 5 years ago. It's just more on consultation, but now we are ready. We have applied for a for this youth rehabilitation facility to happen.
Right. So as far as you know, there's just a single facility in Esperance. Do you know how many people that can accommodate?
Because it's a, I'm sorry, I'm not too sure, but I think it's more than 20, 30 or something like that.
Lovely. Thank you. Just another question. We've heard from a number of other people who've spoken to the committee that they've been concerned about an increasing incidence of drug, but also particularly alcohol related issues in older Australians in the last perhaps 5 to 10 years. Is that something that you've seen and that you've had to accommodate or deal with?
Yeah, we do have an increasing in that sort of cohort, 30s and above. We also have, but it's more on, more on alcohol, and I should say, and yeah, they're all, most of them are self-referred as well. Just at the top of my head, with our current clients at the moment, there's not much in a older categories, but yeah, I think we have seen that in the past, not a recent past.
Okay. Thank you very much. No more questions. Thank you, Chair.
Good. Sam?
All my questions have been answered. Thank you, Chair.
Good. I have one last question. Maybe you could take this on notice. Where does your funding come from?
We're funded by the Mental Health Commission primarily,
Right.
and also we're funded through the WA Primary Health
The PHN.
Network, WAFN, for our outreach.
Right. And do you have any data on the number of people that you see, the number of people who require residential rehab, the number of people you're following up in the community at all?
We do have, so we've got 18 beds in capacity for the rehab. So we use what we call as a wait list. So in that wait list, that's where we try to help them while they're waiting for beds or preparing for them to come to the rehab. So in a year's time, we're looking at more of like 80 to 90 clients in the coming to the residential. Right. With our bed days. So we have bed days as well because it's a 13 weeks program. And we do have some graduation as well. So over the years, we've got 30 graduation, 20 to 30 graduations as well. Right. And yeah, so that's about the stats.
And from what you've been saying, all the rehab does require residential placement. There's no community-based rehab that you can access.
As far as I know, in the Goldfields region, it's more on the residential for treatment service.
Right.
There is community alcohol and drugs, which are more on the prevention side of it.
Yeah. Good.
But we do, we provide residential for the detox and the rehab.
Great. Thank you very much. If there are no further questions from the committee, thank you for your attendance here today. It's been very valuable. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 1st of May. You'll be sent a copy of the transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors. And once again, thanks for giving us your time today. Thank you.
Thank you very much.
Thank you.
Bye.
Thank you.
Now, I would now like to call Ms. Lindsay Fitzgerald from the Jacaranda Community Centre, the CEO, to give evidence today. Good morning, Ms. Fitzgerald.
Good morning.
Good morning.
Sorry, the taxi took me to the wrong Mercure Hotel.
Yeah, I had that issue.
I did that yesterday.
It was weird.
Yeah, he was I'm not quite sure what happened.
Well, you got here on time, so that's pretty impressive. Thank you. I'm just going to go through the formalities. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
I'm Lindsay Fitzgerald, CEO of Jacaranda Community Centre and also the original founder of it in March 2000.
Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceeding as the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement before we proceed to discussion, but I'll also get my committee members to introduce themselves.
Sam Birrell, I'm the Federal Member for Nichols in Northern Victoria and Shadow Assistant Minister for Agriculture and Regional Education.
Monique Ryan, Member for Kooyong in Melbourne and Deputy Chair of this committee.
Mike Freelander, Member for Macarthur in outer southwestern Sydney and Chair of the committee.
Alice Jordan-Baird, Member for Gorton, Melbourne's Western Suburbs.
Ailey France, Member for Dixon in Queensland, north of Brisbane.
I would now like to invite you to make a brief opening statement before we proceed to discussion. Thank you.
Okay, I'm not sure quite if anyone knows what Jacaranda Community Centre is, as you're not from WA. Okay, very, very quick rundown. We were set up by the local community, mainly Aboriginal, on March 20th, 2000. They wanted an organisation that represented Aboriginal people but was open to all people. The elders said they didn't want native welfare 1-2 organisations. We're a not-for-profit. We're also an Aboriginal community-controlled organisation with the majority of committee members Aboriginal and the majority of staff. Programs are made up of both Aboriginal and non-Aboriginal, and cold clients make up a significant contribution in the non-Aboriginal programs. In fact, we had 41 different languages in 6 months. It also has incorporation, public benevolence status, ITEC, DGR, and we've won many awards over the years. We started up without any funds, not even a bank account, and we now run a budget of about $1,600,000 on various grants, many of them different government grants or foundation grants. My husband donated the building for rent-free and paid for the power etc. to start with, and Lottery West then brought us a building which is ours now, which is fantastic. Grassroots, and we are often asked to meet to give local knowledge because our doors are open every day. So, there are many walk-ins. But we run the only Aboriginal financial counselling program in WA, Aboriginal financial counselling and the WA redress program, Aboriginal family support and school inclusion, Aboriginal men's and women's programs, family and domestic violence funding, and financial counselling and general financial counselling, and financial capability workers as well. We don't have a drug and alcohol counselling. To complement that, we get Palmerston to come on side for us, because we know that the people will come to our agency, and if we book them in, they're not going to go to another building. And we also have the Multicultural Women's Fellowship Group there as well, which is large. 26 come from all different languages. So we have different agencies come out there, and Noongar Patrol attends regularly. Now, Noongar Patrol, I don't know if you know, it goes round Perth dealing with issues that are found on the street, or they're trying to deal with those rather than go through the police. So it's a patrol that goes around. So they come in every day to make sure there are no issues that we should be getting them to follow up on. So with the terms of reference, we deal with alcohol and drugs every single day, and it's mixed in with other stuff, so we don't actually have funding for that particular purpose. It just fits in with everything we do. And there are a lot of good services out there in WA, but we're often segmented. One does counselling, one does this, one does that. We try and do a more holistic approach, so bring in services that we need, but work with the client around all our programs, not just one. Government can't always understand that's how Aboriginal culture works, and you know, it might take funding away from one program, but you can't give the clients to someone else that does that program. That's not going to happen. You know, clients like to go where they know who they can talk to, they can understand what's happening. And I know I can't go through all this, but I might leave a couple. And it's working with the whole family. You don't book in a person for drug and alcohol counselling. That doesn't work. Our FTB financial counsellor goes out to about 6 different refuges to work with the women escaping domestic violence. And so many times that is linked to drug and alcohol violence from the perpetrator, and linked to the fact that they may be using drugs. Some may use drug or alcohol to try and get past that, to not have it affect them. And we all know that drug and alcohol doesn't do that. And often there's a mixture too between prescription drugs. Some of the doctors are very good at giving out sedatives, not realising that the person's drinking a lot of alcohol and smoking ganja at least most days. The combination's not a good combination. So we try and work through all the issues and link all the things that we, you know, when talking with the family and talking with the people as to what is needed. You know, the family and domestic violence, suicide. We're dealing with suicides every day. And, deaths, funerals.
Take a minute.
Non-attendance of children's school, lack of employment, lack of self-worth and determination, lack of a constructive future for the reliable future, no reliable income that supports the needs of the family, and it can't be dissected and put into little boxes. You can't say, right, you have 10 issues, go here, 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 here. It doesn't work. They all come in and pile on, you know, into it to try and split to see what we can do. So we think the answer to the first question is wraparound is the only way to go. It's the only way that works with the Aboriginal clients that we've worked with. And I mean, I've been running the agency since 2000, and that's what we've seen can happen. But the funding isn't wraparound funding. Funding is often for 1, 2, 3, 5 years, and you may not get it again after that. There's no guarantee ever. We lost some funding, and they didn't do it for Southwest area we were doing anymore. Country got it, and Country need it. But to try and close a program when it's been successfully running for 14 years is very difficult. And, you know, comments like trying to give the clients to another agency, I found that felt like giving a bag of groceries to someone. You can't give people to somewhere else. They have to get the best results, they have to want to go, and they have to want to know that you understand what's happening, want to know that you know a bit about the family history, how they link together, and we do family trees to work on that a bit more. So though, you know, some will say there's plenty of services funded out there, the difficulty is how many are allowed under their criteria to do that holistic approach of everything and be funded for enough money to do that. Most of our funding is program itemised, and not all programs link up at all. So I think that's one of the issues that happens. I know you've probably asked me a lot of questions, so
we might
leave there and then you can ask them on them, because I've got such a history, I don't know where to go with that.
You clearly are very bonded to your community, and we appreciate your passion. And I'm sorry if you were upset before, but we, very grateful for you coming today, and you clearly speak for the community, so it's great. We might start with Monique, if you like.
Thank you, and thank you so much for what you and your husband have done. It's a generation of generous contribution. It sounds like you've done an amazing job within your community. Over those 26 years, how have things changed in terms of the alcohol and other drug issues that you're dealing with on a daily basis?
A lot more violence. And I mean, we see it in the agency. We see women running through the door and hiding under our desk because someone's, he's chasing them. He's taken their key card, gone to get money out. There's no money left because obviously he's had it out a few times. And so what's happened is he gets angry. He's high on drugs still. He's got alcohol in his bloodstream. And all we can do is try and shut all the doors quickly, call the police and the council security and get them to see if they can find him. Normally he then runs through and jumps over the back fence. It's not an everyday occurrence, but there was one in today that that's why I was almost running late. But Charlene, my Aboriginal financial counsellor, is going to see them, and she just couldn't go back into the house. So it's like they're not ones that are going to ring and say, this is what I need, this is what's happening. They'll come into somewhere where there's a door open, and that's us. So she will spend quite a lot of the day trying to sort through that, get the lady safe, make sure she's medically all right. We have a doctor along the road. And it's just a continuation on of that. When she has a full workload, I think she's got 96 financial counselling clients on her books at the moment. So, this is where it's difficult. And Uncle Vanna said to me, he's an elder that works with us just a few hours a week as he's on dialysis. He said to me, sometimes I can, even at home with different family, I can talk the person into understanding that they need help, agreeing to it, and then I can't get them in the most appropriate places straight away. And by the time you've tried to talk them into having an interview, maybe group sessions first, it's gone. It doesn't happen. They just never get that help. And that's really unfortunate that an elder can see that, but can't do a lot with it, you know, other than talk to them.
You said more violence.
Definitely.
Do you think that it might be hard for you to know, but do you think that the drugs that people are using have changed over time and that's contributing to this increase in violence?
Definitely, because there would have only a lot took ganja, a lot, the Aboriginal word for cannabis, and I've been there so long I've used the same words. But now it's getting stronger. It's getting into you know, different forms of tablets, mixtures even that definitely aren't pure ones from where they're obtaining them. Occasionally we hear of where someone we think might be selling them, and a quiet word with the police, but they're very clever at leaving before the police can get warrants and search, and that is very clever in that way. So I think that does. Also over time, I think with the amount of alcohol increasing as well, not eating the right, you know, good foods, and things like that, their body is not able to take things, and then the sleeping tablets on top of that. The dose might say 1 a night. I tell you, they are not taking 1 a night. Sorry, we had a mother who was supposed to get her children on a school bus, Aboriginal school bus every day. She didn't wake up. So, and they never went to school most of the time. So I think, you know, it's that combination now we see, rather than a particular substance all the time, and how we stop it. I mean, we have meetings and we talk community, talk about it, and you know, the elders have elders meetings to talk about different issues, but no one's actually been able to say this is going to stop it, and I don't think in my lifetime it will.
Do you think that women understand about the risk of fetal alcohol spectrum disorder, Kathleen?
We have Aboriginal Health come out for that, and we do. We work with a lot of research from the universities to explain that to them. Some do, some don't, because we still see them smoking along the street, and you even sometimes see them drinking. The council put a park bench outside our building, worst thing possible. We've seen, not the women though, the men, injecting themselves in broad daylight on a chair. And by the time, of course, we've contacted, it's too late, they've gone somewhere else. They leave their needles there then, and trying to get it removed is difficult. So I don't know what the answer is. We are getting better at getting together and trying to work through things. The ACCOs were very, not divided, but we were individuals as such. And we've got, and I will leave you this afterwards. So CASWA is the Council of Aboriginal Services for Western Australia, and they're the peak body for ACCOs. So they've come out with a strategic plan, which I've got here, and we're also looking more at the national plan, the government's national plan for the children, women and children to live free from violence, linking those two together and working on how we're going to achieve that. Part will have to be discussing with making sure that the government understands culturally you must have wraparound services.
Yeah. We might get you to submit them as evidence. So
yes, I will do.
Great.
Thanks, Chair. Thank you.
Good. Sam?
Thank you, Chair. Thank you for your evidence and the way you presented, and for the work you're doing. And it's obvious how much you care. So, on behalf of all of us, thank you for doing that. I come from Northern Victoria, which is the Yorta Yorta area, and we're dealing with, I won't say similar, but issues, and working through some issues of economic empowerment and cultural change within communities. And so I suppose I explain that to give some perspective to asking you about cultural change within communities, and particularly around the empowerment of women, and trying to shift women's agency within communities and relationships. Is that something that is possible, or?
I think it's possible. We've actually got the only 3 Aboriginal financial counsellors. We took 2 Aboriginal people. One had been a client, women, that we thought they were strong enough to be able to train, and the government gave funding, a one-off only, for a couple of years, and we've been subsidising that everything. They're now fully qualified financial counsellors, but the women need a lot of support to go from where they were to where it needs to be, and it needs to be ongoing. They're brilliant role models, but it needs to be ongoing to see that and they see so much despair. They're the ones, over 80% of Aboriginal women are the tenant on the lease for state housing in WA. So they're the ones that look after the children, they're the ones that have to sort out all the medical and everything else. So I can see that it has improved. The general community says, though, that the respect from the younger generations is not there like it used to be. Respect for an elder was absolutely everything years ago, and Uncle Vanessa respect, but the respect isn't there that used to be. A different culture has come on board with that, and it's the same, the respect for children to women or their mother, and I think we're going to really need to almost reverse that a little bit to get things to change. And sometimes it's just the despair. Jobs, you need driver's licence. Half of the guys haven't been to school for long enough. Do you know how much it costs to get training for a driver's licence? And you have to have a reputable car? Out of the question. End of the jobs series. Mines. Their jobs network might put them through to a mining company. The minute they do a drug and alcohol test, that's the end of it. Or if they do go away, and I've got an example in some things I wrote, it's like the grieving from a suicide, say, and there's no one out there, there's no family. That's the time when you have masses of family round, because we often get phone calls to say that there's issues with the number of people. So that stops all that side of employment, which might give it empowerment to males and females in jobs, but definitely more with the women, because they're able to handle things that are easier for them and not all these other issues as well. And I think it's really important that we keep on doing that. I'm going to find someone that are fund more trainees so I can have them on board, because in this 2026 we only have 2 trainees that have qualified. Well, that's the only money we've had. That's terrible for a statistic. It's something none of us should be proud of. But trying to get money for more traineeships and to look at how you do them, how they can be on the job, how you can be flexible to their family, you have to have a service that's willing to put in the hard yards to do that. But they're fantastic workers.
Good.
How do you find, I won't assume, but I'll ask, about the balance of trying to get some cultural change within the community that you're working in, maybe trying to isolate some of the children from some of the things that they're dealing with, and then the cultural safety lens and some of the nexus between all that. Do you find that difficult?
Yes, definitely. It's a hard case of knowing whether the children would be safer away from immediate family. Sometimes it's not going to work in the way that, it's looked at, let's find culturally someone, a distant family or something like that. that doesn't always work and creates a lot of family feuding. If we were able to spend more time with all of the family, then maybe, you know, it could be looked at, but they tend to, if the child is taken away, do you know how hard it is to get them back? They have to jump through hoops. I know I went to the children's court one day and they said, oh, but I hear they've had food vouchers from you. And I said, of course, you've taken their family payments away from them because you took their children away. How do you expect them to go and visit them and provide the same amount of things as the foster parents do? So it was like, don't you understand sometimes what you're doing? They're still a mother, they're still a parent, they still have children, they're just not actually in their house at the moment. And I think if you put enough resources in to that over a variety of issues, then you wouldn't be taking as many away. Definitely wouldn't be taking as many away. You know, shouldn't be take the children then ask questions. It should be really looking at how can we work with them within the environment they're in, and how can we change that environment to be safe for them.
Okay, thank you. Just a real wrap-up question. I know my colleagues have got some questions, but you just used the word. The words that have struck me are the words despair.
Yes.
But also the opposite of that is hope.
Mm-hmm.
But you're really emphasising that the wraparound full service of the family is the way to try and engender hope into the lives.
Definitely, yeah.
So we've heard the phrase "no wrong door," so that when people come to one place, they get all the services. Is that sort of what you mean?
Yeah, that's what we try to do with limited funding where we are. They might come in for a food voucher. The family will probably be known to us. You know, I've got a lot of Aboriginal part-time staff, but I've been part of it for so long. They all know me. In one court case, she said, "Oh, this is my white auntie," asked her. One said a white mother and one said a sister. Fortunately, the magistrate did understand in the end. And you just learn, you know, those different things. I don't want there to be despair out there. I think we can change it. I think we can, you know, like we can't run programs at the moment because for some of those issues, we do have a room where we do have family meetings because if you don't involve the family, if you only involve the person, it's not going to work. Definitely not. And there's other things as well, like the overcrowding is extremely bad. You know, and kids, I know because I'm working with some teenagers, they leave home at night and sleep around or take drugs or something because their bedroom's used by other family members. When I go around there, I'm always welcome to walk in. There's mattresses on the floor everywhere. Then you get the complaints for, you know, the noise or the overcrowding. So there's that sense of despair there in how do they get from that of leaving home during the night because they don't want to, there's nowhere for them to sleep, to actually finishing an education and getting employment. There's employment out there, I agree with that. It's how we get people trained for it, how we support them to do that, you know.
I might just want a bit, because I think there's some other questions.
Yes.
Alice, do you want to?
Yes, thank you. Thank you so much for sharing a little bit about your organisation and thank you for all the work you do in your community. Clearly you saw a need back in 2000 and you've just grown and expanded that, so thank you for sharing that. And as Mr. Birrell mentioned, we've sort of heard a lot about, you know, no wrong door approaches, and it's clear with the number of services that you have, and you have, you know, external services like Palmerston coming in. We heard from them yesterday. It sounds like you're doing exactly that, which is wonderful. My question is around, do you have an age range of the people that you support? Is it over 18s or is it all ages? Is everyone welcome?
The Aboriginal family support is from preschool to when they leave school, and supporting them to that's to support them to get an education, to get the schooling. But when they've had years of no schooling, they haven't had that start. They haven't gone to a preschool or a kindy. They haven't gone to a playgroup. They're behind. And if you look at the juvenile justice stats for Aboriginal people, you'll find that actually, if they haven't linked in with education at early age, and especially preschool and year one, they're more likely to offend. And, there are stats out there that look at that. So you have to do the whole family. Gets very difficult because that is only for families with children. We used to have one that was family support, but it changed for the schools. So that means that other people that, if they're grandparents that look after children some of the time, we can sneak it through even if they're not on their cards. But you're not officially supposed to work with some of the other issues that are outside that criteria. But in saying that, it's an Aboriginal program. You can't just divide it up. And so that does mean that we can give stats on this information, and these stats we keep and try and work around the hours for it, which does overload workers if you're not careful to do that. So our elders would be up into, we've got a couple in the 80s, 70s, 60s, not a lot. And we're having so many funerals all the time, which affects the workers, it affects us. And on top of that, as I said before, the suicides, they're extremely hard to deal with. Such a waste of life. But, it's how do we stop it? How do we give them, what we were talking before about, give them enough self-worth and want for that not to occur? How can we find that out in the whole community, not just with us working to do that? So that's where it's difficult, because it'll probably be someone related in some way to one of my staff. So that's even more difficult.
Thank you so much for appearing today. We really appreciate it, and it's good to really hear those feedback from on the ground services at the front line. So thank you for all that you do. I was really happy to hear of the story you told about uplifting one of the women into and being able to train in to become a financial counsellor. Do you have, sorry to put you on the spot, but do you have any examples of where the wraparound support services have helped specifically in the alcohol and other drugs space? Do you have any examples of how, whether referral or people being able to go to a service detox, any positive experiences?
Yes, we do. We used to have a centre they could be taken to, but that's closed. But, there are people that we've assisted to get into training that have been homeless before. There has been alcohol issues, at least, someone drug, that they've been able to work beyond that and get some employment. And, one of mine workers, and she's said it before at meetings, and I said, without our support from having her as a client to getting her as a trainee, she's not quite sure where she would have gone, which avenue she would have gone down, because housing was such a big issue, homelessness is such a big issue, that to do anything else and get on your feet is extremely hard. And you need to, and as she said, you and Uncle Venice believed in me. And I don't think there's always that belief out there. Yes, you have to be professional and have boundaries, definitely, and with our normal clients, if it's not linked to my staff, it's easier. But where's the belief in their ability to do something? If you believe it, they will believe it. And that sort of support is hard to gauge, hard to give records for, other than to say this person's got a job. One of our clients in the family support did some parts with Yuri Yark in the dance company and play company, and she loved it. We had some that did the ABS stats on our agency. They came and did those and got paid to do those, which was lovely. They're also part of, we've got some that we've got to be part of research. AREMA does a lot of the federal government research, and when there are Aboriginal issues, like even like are the pamphlets suitable for Aboriginal people, etc., we will invite them to come along and share their knowledge and skills in hoping that government gets it right. And the pride they have in doing that is exceptional. Now, it's not a paid job as such. They get a token, but it's the fact that we've accepted that they have knowledge and skills that are going to be very useful, and they are. They always come through to us and ask for that, and there are a large number of people that will do that. We had the most people, we had 100 Families WA, a program that went for a few years with UWA, following families and their journey. And when they did a take of who was the most vulnerable at the time, it was 33% were my clients with that. And they loved being part of it. They loved being accepted as having knowledge and skill. They turned up for their appointments every fortnight. They turned up for group meetings, and they wanted it to continue, and other people heard about it and wanted it to continue too. So that's other jobs that you can start them off with before you look at the education side of where could they be educated that would help them. And so there are successes like that, and we try and use those as much as possible for the community to see that you can start achieving. You don't always have to be in, where we've virtually put them over time. So I think that's really important.
What you're saying is basically if getting them into training and giving them some agency is just as important as alcohol, drug detox centres and things like that. That drives it,
definitely,
is what you're saying. Yeah. Thank you for that. Yeah. Appreciate it.
Good. Got one last question.
Yeah, that's fine.
How and why did you get into this?
How the Aboriginal community asked me to. I was doing welfare work for an agency, and they said, we want you to start up one for the community. And I went home to my husband and I said, it'll be theirs, it'll be incorporated, everything. I'll need financial support because I'm giving up my paid job to do it. And he agreed. And he's not in that industry at all. He's retired now. Because I could just see that they trusted me enough to say to me that's what they wanted. And I thought, you can't just put something like that aside and say, I could, no government funds, and I get paid here. Why would I want to do something like that? But that wasn't. I also trusted them that they would support it all the time, and they would make sure that the community knew about it and knew what could be achieved by using the services. So it was a win-win for both of them, us and them in that way.
Good. Well, thank you very much for your evidence today. It's been very moving and very impressive. I think we'd all agree with that. and keep up the good work. I know that the funding issues can be difficult, and
It is. Takes a lot of time. I think that's what people don't realise. We don't have a research person. We don't have a grant writer. We only have a bookkeeper. He's in at the moment doing the pays once a fortnight. You know, all those things are what we all put in together to do.
yeah.
And so sometimes, obviously, maybe our grant application won't be as professional as
Sure.
having a professional do it, but it is grassroots, and if they see through that, then, you know, hopefully they understand what can be achieved. And
Sounds like you've achieved a lot.
yeah, and I just love doing it, as you can see I always do.
Yeah.
With
So
that.
if we can have copies of those documents,
Yes.
that would be great if we'll submit them
Those
to the
ones
Secretariat.
there,
Yep.
and that was just, I didn't go to script because obviously I wouldn't have had enough time,
Yeah.
but I have one of those. Do you want them sent in and copies, or? Yeah, that's fine, I'll do that.
Great. Well, thank you very much.
Thank you for your time. I probably not answered in the right format, but
No, you
I think that you're going to hear from professionals that have certain things that they have to do. I wanted you to hear from grassroots to understand what's out there at the moment, and then try and think of better ways of achieving things. We can achieve it. We can get it better. There's no doubt we can. It's just
Good.
how.
Well,
Thank you.
On that note of optimism, thank you for your attendance here today. If you've been asked to provide any additional information, would you please forward it to the Secretariat by the 1st of May 2026? You'll be sent a copy of the transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thanks very much for coming today.
Thank you. Thank you.
Good. Now, I will now call witnesses from the Alcohol and Drug Foundation New South Wales, Dr. Latha Nithyanandam, the CEO, who's appearing online, I think. Dr. Nithyanandam, you're on mute. Can you please unmute yourself?
Oh, yes. Good morning, everyone.
Good morning. How are you?
I'm good, I'm good.
Good. For the Hansard record, would you please state your full names and the capacity in which you appear before the committee?
I'm Latha Nithyanandam. I'm the CEO of Alcohol and Drug Foundation, New South Wales, and we have an organization, Kathleen Yorkers, under the ADF NSW, and this is a service for women and children, and we take children up to the age of 10, and it's a long-term 6 months residential program for women with drug and alcohol.
Good.
Substance use disorders, yeah.
All right. Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a brief opening statement before we proceed to discussion.
Sure.
Would you like to make a brief opening statement?
This is about the impact of drug and alcohol, isn't it?
Yes.
Yeah. Mine is I come from a women's services, and I'm also talking about many of the women's services. We work quite closely together, and when women come here, it's a wraparound service. So our service is we work on drug and alcohol, but then we work very, very closely with the community, because we realize that, it takes a community for the women to get back to their lives. And so it's a long-term 6 months program. And when women come here, we take care of the biopsychosocial-spiritual side. So which means, literally many of these women who would have come would have lost their children, or they come from jails, or they have lost their houses. They are on the verge of losing their children. When they come in here, we support them totally, along with other services like the local subs team, with the medical services, with everybody around, including schools and daycare. And by the time end of 6 months, we support them to, in fact, get back their children if they have lost their children, or fight very strongly, advocate for the women to have their children with them. And by the end, we try to get them housing, try to support them so that, they are able to lead an independent life. So we also have a 1-year aftercare program where we support them. To a great extent, we wean them out slowly. So the medical, and the work we do is not only the intervention for the women, but also we see, as a preventative, we look at the women's story and we realize it's not very different from what the children are going through right now. So we do interventions for the children also, with the purpose of trying to stop the transgenerational cycle of addiction, so that, this is also a service where we look at so that the children don't have the same problems, and they also come with the same trauma background. And so we try to work with the children also.
Can you just explain to us where Kathleen, your house is geographically?
It's in Sydney.
Yeah.
It's in Sydney region. It's in the city, inner city.
Yeah.
At Glebe.
Yeah, and where do the referrals come from?
Normally it's statewide, but there are sometimes when we get from outside the state also, but mainly it is statewide. But there have been times when we've had clients from Queensland and from Western Australia, from South Australia and other places too.
Yeah, and the main difficulties of the clients are alcohol, or is it other drugs, or is it a combination of both?
It's a combination. Earlier it used to be specifically, but now it's become, poly users, and we are seeing more and more a trend of methamphetamine with other drugs, and also a lot on alcohol.
Right, and it's a residential program over 6 months?
Yes.
Good. I might just open it up for the committee to ask questions. Monique, would you like to?
Thank you. Thank you so much for appearing in front of the committee today. So the women who come to your facility, how far away would they come from? I know it's a broad question, but...
It could be from anywhere, like as I said, from statewide, or from Dubbo and places like that. Like as I've said, I've had some clients even coming from Queensland, because it's a 6 months facility. We support them through that 6 months. And by the end, there are many women who would want to continue being in Sydney, or there are some people who go back, and then, we work closely with wherever they come from and try to refer them to the local services there.
It sounds like a remarkable initiative. Thank you for undertaking this work. How are you funded, and what challenges do you have in that respect?
Oh, we are funded 55% by the state health department and 45% by the central, by the Commonwealth. And we need both the funding to sustain, because, we are able to run this service with both the funding. So it's only through the state and Commonwealth, the health department's funding.
And so you've been able to secure long-term funding. You've got a reasonable degree of security around that.
Yes, we've been having for quite some time, and only now recently, when we saw that, the Commonwealth funding is going to be competitive, we are very, very worried, because they want to have it less number of contracts or something like that. So we are worried, because if one funding goes, we don't know how we are going to sustain. We have to go to the state and they have to prop us up. Otherwise, it's going to be a nightmare.
Mm-hmm. Okay. And you're able to accommodate people at short notice. So, do people telegraph that they're coming to you if they're coming from a place like Dubbo, or did they just appear on the doorstep?
No, they don't appear on the doorstep because, we have children there. We have a little assessment process. Sometimes because it's a small service, we have at any time we can take women up to 8 women and up to 5 children. But then, we also, when they call in, if we are not able to accommodate, we try to refer them to different services so that, whoever calls us gets some kind of support from us.
Great. Okay, last question, if I may. Someone comes to you, spends 6 months with your service, goes through a successful process of rehabilitation, and then goes back to the regions, to Dubbo or another regional centre. Are you able to provide any follow-up supports, or do you have to just refer to local services at that point?
We've had different systems, but thanks to, this is the only thing I'll have to thank to COVID, is after, doing things online, we do support them online also. Sometimes, there are women who still want to do our aftercare as a 1-year program, where if they can't do locally, they want to be supported from there. And so we've individualized that aftercare program so that they are still in contact with us. And we try to work with the local agencies to see if FDS can be done for them. And so, we've worked very strongly with people who go outside our area too.
Thank you so much. Thank you, Chair.
Good. Alice?
Thank you so much for appearing before our committee today and for all the work you do in your community. In supporting this cohort of women and children, there's a lot of different agencies involved in coordinating this care. So there's, child protection, family violence support, housing, AOD treatment. Do you think there's a need for a sort of navigator role to support this coordination? Does this exist already, or what's your views on this?
We work very closely with all the whoever they come with. Like, say for example, if they have child support, DCJ direct. Oh my God, it's. Like if they have DCJ involvement, and then or if they are coming from corrective services, we work closely with them. But once they come in here, we also work closely with our local GP, and because these women would not have gone to the hospital for years or had any kind of medication review. So the first thing we do is we work closely with our local medical practice. We also check on all the gynec needs and things like that. We are very close to RPA hospital. So if there are babies or children or a pregnant women, because we also take women at any stage of pregnancy, pregnant women, we connect them to RPA and with the subs team. And also, once they come in, if they come in with small babies or they've just delivered their baby, we work closely with Tresillian services because, on mothercraft and supporting the women in nursing and, in taking care of the babies. And then we also support the women if they have children who are a little few months older, so that they go to the local daycare program, and if their children are older than 5 years, to go to our local school. So we coordinate closely with all of them, and also with housing. After they finish the 6 months program, if they are going into aftercare, we try to provide them 2-year housing. With aftercare, we work closely with Metro Housing and other places. There are some people who go out of the area. We try to support them with support letters and things like that. So it's not just us. We are working with a whole lot of other agencies around, and we also prioritize pregnant women and Aboriginal women. So if there's anything to do with Aboriginal women, we get their services to help us, to navigate through so many things based on their needs.
So it sounds like your house is playing that sort of navigator role. You're coordinating a lot of this yourselves. Would that be accurate?
Yeah. Yes.
Okay.
Yeah.
Thank you. No further questions.
Sam?
I'll have no questions. Thank
Good. Look, I've got a few questions. You say you've got a 1-year aftercare program, but presumably many of these kids will have ongoing issues, be it learning or behavioural, etc., or even growth. Do you have the facility to be able to refer to paediatric services throughout the state? Do you try and coordinate those sort of issues?
Yes, we work very closely with DCJ if they are involved to get some kind of support for the women, and sometimes even at our local centers there have been times, and we also work closely with child psychologist nearby, and as also a speech pathologist. So based on the child's need, we try to refer them to different places, and at times we have our own art therapist and music therapist. So sometimes, the kids have also, if they think it is if the therapist think that that will support them, we have even found excellent outcomes with art therapy with the children. So yes, we try to see what best we can do for their behavioral issues, because these children are equally traumatized as their mothers. So we realize they come from DV backgrounds, and so we look at intervention immediately, not wait for something to, for it to come out later.
But for example, if you're seeing families from, say, Dubbo, do you then refer back to the paediatric services in Dubbo, or do they have a relationship with the schools that these kids may
We've
go
not
to?
had that scenario, because when it's outside this thing, mostly they build their relationships here with children. But if it happens, I'm sure we would be looking at it, because it's a 6 months program. We work quite hard from the beginning, because we want to know what they're going to do in future, and if they're going to go back to wherever they say they come from, we look at the local services there and connect them before they leave.
Good, thank you. No further questions. So thank you very much for appearing before us today, and grateful for your input. You'll be sent a copy of the transcription of the meeting today, and you are welcome to make any changes that you would like. If you've been asked to provide any further information, if you could give it to the committee by the 1st of May, that would be great. But thank you once again for appearing before us. Thank you.
Oh, thank you. Thank you very much for inviting me. I don't even know how I got invited, but I'm really happy, because we are quite worried about, the funding that's competitive funding that's going to happen. And it's going to take away all the networks that we have set up. And that's another big worry we have, what's going to happen for the future.
Your funding is mainly through the New South Wales government, is that right?
It's 45%, 55% New South Wales government, and 45% by Commonwealth Health Department.
Right.
The
Okay.
NAP program, yeah.
And when does that funding finish?
They say they're going to extend it till 27, and then it's going to be competitive. So they've extended, so only till 27 we are funded with the DAP program, with the Commonwealth. So, we have to have it working in tandem, otherwise it becomes difficult. All these years we've never had the problem. Only this year we are quite worried, and, we are feeling the heat.
Sure. Okay, well that competitive tenders are beyond the committee's remit, but it sounds like an extremely valuable service that we wouldn't want to be lost. So thank you.
Thank you very much. Thank you.
Thank you.
Bye-bye. I'll now suspend for a short break, and we will reconvene at 11:15. now. Sorry, start again. We're reconvening the Standing Committee on Health, Aged Care and Sports inquiry into the effects of alcohol and other drugs. For the Hansard record, would you please state your full name and the capacity in which you appear before the committee?
My full name is Jocelyn Dew, and I'm the Deputy CEO of DASA, Drug and Alcohol Services Australia.
Right. Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement before we proceed to discussion. Before we do that, I'll get my committee members to introduce themselves, starting with Sam.
Sam Birrell, member for Nichols in Northern Victoria, Shadow Assistant Minister for Regional Education and Agriculture.
Monique Ryan, Federal Member for Kooyong in Melbourne and Deputy Chair of the Committee.
Mike Freelander, Member for Macarthur and Outer South Western Sydney and Chair of the Committee.
Alice Jordan-Baird, Federal Member for Gorton from Melbourne's Western Suburbs.
Ailey France, Member for Dixon, north of Brisbane.
And I'd just like to invite Ms Jocelyn Dew from the Alcohol and Other Drug Services Central Australia to make a brief opening statement. Thank you.
Thank you. So, good afternoon, everybody. My name is Jocelyn Dew. I'm an Eastern Aranda Bunjama woman, born and raised in Alice Springs, Northern Territory. I am here today in my capacity as the Deputy CEO of Drug and Alcohol Services Australia, which is commonly known as DASA. Should I still continue with my brief?
Yes, thanks.
Okay, thank you. So today I want to discuss the specific issues facing our organisation and our community. I'm aware of many submissions provided by peak bodies and academics which contain helpful data and evidence. I want to share with you some of the realities of operating in this space. DASA has spent more than 40 years shaping hope in Central Australia, rising from a small circle of determined community members who believe change begins with compassion. What started as a vision to support people facing alcohol challenges has grown into a powerful commitment to uplift, not to punish, to walk alongside people as they reclaim their strength and build a healthier, more connected community for everyone. We currently deliver a range of programs, including a 16-bed sobering up shelter, residential and non-residential alcohol and other drug programs, a drink driver education program delivered in Alice Springs and across remote communities. More recently, we have expanded our service to include residential alternative to custody programs, one for Aboriginal women in Alice Springs and another for Aboriginal men on Groote Island, which is on a very remote island east of the top end of the Northern Territory. We know that the work we do matters. We know that it works to change lives, perhaps even save them. Yet we battle continuously for sufficient funding to keep our services operating. The amount of unpaid labour that the leadership of DASA contributes is enormous, but love alone cannot keep doors open. Our alternative custody program has been evaluated and has proven to have an almost opposite effect on reoffending rates, meaning that a woman who goes to prison is far more likely to reoffend than a woman who completes DASA's alternative custody program. At DASA, we recognise that harmful drugs and alcohol use is fundamentally a health issue, not a justice issue. We urge the government to allocate funding accordingly, stop building prisons, start addressing the health concerns that is addiction. This is not a criticism of any government or funder, rather some examples of the challenges we face at DASA. And some of the examples include the primary funder of Aranda House Therapeutic Community, which is a 20-bed residential facility, does not even fund it enough to operate 24 hours a day. To stay operational, we have to seek top-up funding from 2 other funders. Aside from the inconvenience of additional reporting burdens, the risk of the program is high should one funder withdraw support. Aranda House Therapeutic Community has been operating out of the Northern Territory government-owned asset for more than 30 years. In the most recent flood event in Alice Springs, which was in February, this site was damaged so much that we have had to evacuate our residents and run a modified program out of some demandable buildings at the rear of another not-for-profit service. What is worse is that there is no money and no ability for the NT government to provide our service with a new facility. We are left to do unfunded work to secure alternative options and find federal funding. A 30-year service just made homeless overnight due to flooding. Our alternative custody program work, they operate on evidence-based models of care and cost less than prisons. They focus on the whole person, rather just of the offending of substance use. This works, yet the prison system gets bigger and bigger and harm continues to increase. When we were funded to deliver the alternative custody program on Green Island, no funding was provided for vehicles for more than a year after operations commenced. To ensure the program could run at all, we supplied our own vehicles in kind, then went on to battle for months to have funding already allocated to us for other operational purposes to receive approval to purchase vehicles instead. This facility is a 1-hour drive from where staff are required to live in demandable accommodation. 20 minutes of that journey is on unsealed dirt roads, and most of that drive is outside mobile phone coverage. Yet, here we were begging for vehicle funds. To be clear, alcohol and drug harm does not just impact Aboriginal people. That is just what the public can lay eyes on already. The reality is that alcohol and drug harm can impact anyone, anyone's husband, wife, father, mother, child or friend. You never know when you might need our service or one like us. Yet we continue to be expected to deliver services out of rundown, not fit for purpose facilities with pieced together funding, battling every step of the way to keep on changing lives for the better by reducing harm to individuals, families and communities impacted by alcohol and other drug use. We understand this is not a trendy topic and it's not a popular issue to fund, but the need is undeniable, urgent and growing. Proper needs-based funding needs to be invested in now. It is long overdue. Drug and alcohol harm is not going away. The increase we have seen in methamphetamine use across the Northern Territory confirms that. Now is the time to invest well in prevention, education, treatment, harm reduction, aftercare and family support. I'd just like to thank you for your time.
Thank you.
Thank you.
We might start with some questions. I'd sort of like to open up. Do you have any data on the number of people that's involved in your service?
Yes, I do. I don't have that data on me, but I can. I don't have the information on me, but I can.
Well, maybe if you could take that on notice and send it to the committee, that would be great.
What I would tell you is that when I first started here in 2012 in DASA, and I can give you some accurate data as well, as when I first started, we know alcohol was predominantly, the principal #1 drug of concern, and it still is. But and then there was cannabis, and then there was methamphetamines. What we're seeing now is that it's still alcohol, but methamphetamines has now went into second place now. It's the second principal drug of concern.
Would I be correct in saying that it's often in combination, that people tend to mix and match?
Yes, you are correct. People do polydrug use, and if they can't get one, they will go into the others. But we are starting to see it more and more in remote communities. We have a methamphetamines outreach program, and that commenced in 2017. And when that program first, it was a pilot program, a majority of the clients were non-Indigenous. We are seeing that shift now to see more Indigenous people in remote communities that are using methamphetamines.
Yeah. Now, I'm assuming that a lot of your clientele is Indigenous, but
that is correct.
Are you also seeing other groups involved now more?
Still predominantly, we are seeing a lot of Aboriginal people come through our programs, but sometimes we have seen a shift when I talk for Aranda House and residential program, we have seen sometimes it's been more non-Indigenous than it has been Aboriginal people.
Yep.
that come through, but majority of the time it is Indigenous.
And we've heard from other services around the country, not just Indigenous services, not just in rural or remote areas, that housing is a major problem.
That is accurate. We have a sobering up shelter here. It's a 16-bed facility. Homelessness is a massive issue across the country. From our stats from this morning, I think there was about, I wrote it down somewhere, there was about 160 refusals, something that we've had in the past couple of months of people because our facility has been at capacity. That provides a safe place for people that they can sleep. And so we're starting to see higher numbers now that are coming through.
Right. And how much of your funding is the state government or territory funded, and how much is federally funded?
Can I take that? So I can give you accurate for that. We do receive NT government funding, so our program. So we've got the Aboriginal Outreach program, which is 100% federally funded. That Pacific program.
Right.
So we have a few different programs that are federally funded that are NT government funded. So the Jacaranda House, for example, a majority of that, 80% of that, is NT government funded, but it is topped up by federal funding from the IAA.
Right.
Yeah.
Good.
I can also take that on notice and get you back that data as well.
That will be excellent. Thank you. I've got lots of other questions, but we'll open it up to the rest of the committee. Sam, do you want to start?
Yeah, thank you. Thanks, Jocelyn, for presenting to us. Over the last few years, probably going back 3 to 4 years, we've seen the whole of Australia's seen a lot of what has looked like a lot of trouble on the streets of Alice Springs and a lot of challenges around violence. To what extent is that fueled by alcohol and drugs, and is it alcohol or drugs or both? And is that situation moderating, or is it as bad but we just don't see it anymore? And are there solutions for that into the future?
Good question. Okay, so from what I can tell you from our stats that we're seeing here at DASA, I would have to say for the clients that we see through here, at least 95 to 97% because of alcohol-related or drug-related offending. That's what we see. In regards to the antisocial behaviours and stuff like that, that has increased. But I feel because Alice Springs is a small place and because it's out there on the media a lot more, that people kind of get this idea that, it's really bad here. But when I turn on the news and I look at what's happening in Queensland or what's happening in New South Wales, it's happening everywhere. It's just most probably not reported, but I suppose as much as what Alice Springs is, there seems to be a bit of a spotlight on here. But I must say, from my own personal perspective, being a local Aboriginal lady born and raised in Alice Springs, it has increased. I still don't see it, getting any better at the time. There are a lot of programs out there that are trying to do their best to, return people back to community that might come into Alice Springs because of whatever reason. It could be a funeral, or there could be an event that's happening and then they get stuck in Alice Springs, and then that also increases the antisocial behaviour and stuff like that, and drinking. So I know that there's services and stuff that have been trying to work very collaboratively in trying to get people back out to remote communities and stuff. I hope that answers your question.
Yeah. Do you think that a big part of the solution is getting people back to communities, or and not staying in places like Alice Springs if they're not sort of have an employment region to be there?
Look, if they're not from here, then maybe I think it is. Sometimes what we see is a lot of people. You do see that, but I think I think there needs to be multiple different approaches with this. You can turn some people back to communities, but there's still issues happening here in Alice Springs. So I think working collaboratively with organisations and trying to address the homelessness issue, because that and the overcrowding issue that we're seeing that's happening with a lot of families here in town. So honestly, I couldn't give you what is the answer. The way that we work is when we're working with clients individually, we try just to support whatever those needs are. And if housing is what it is, we try to do the best and try and find some alternative options. And unfortunately, sometimes that's hostels or whatever that looks like for them, so they can be safe as well.
Thank you very much.
Thank you.
Ali.
Thank you so much for appearing before us today. I just have a question about your women's service and how it operates. Do you find that there are barriers to women getting into your service? For example, how do you cope with women who want to access treatment but have children and caring responsibilities?
Yep, absolutely. So with the women's program, that first commenced in 2019. DASA had taken over from another organisation in 2020, and it's a 10-bed facility for 6 months for Aboriginal women only. We have a referral group that any referral that comes through, that goes through our referral group, and we have police, prison, community corrections that sit on that referral group, and we make decisions around eligibility. The way that we determine is whether someone's at risk of offending or reoffending, and so we have an eligibility criteria that we go through. And then whether we'll accept someone or not accept someone. When we originally took over that program, it kind of organically grew. So we had women who wanted to have their children with them. Because it's only a 10-bed facility, and the site that we use, it wasn't actually meant for that. It was just a student's quarters for short term. So we had a number of issues when we first took it over. And then, like I said, it organically grew, and we started to allow mothers and babies come in, but only one child, unfortunately, because what happens is one child actually takes up a bed. So that's also some of the barriers that we have to consider. And as much as I would love to be able to say, yes, we'll take everyone's child, unfortunately we can't, because that's a bed that was taken away from another woman.
Thank you.
Yeah.
Monique.
Thank you. Can I ask about supports you might be able to offer to younger Australians, people aged less than 18? Are you able to provide supports to adolescents as well, children and adolescents as well as adults?
Unfortunately, no. We're only funded for 18 and above. We did have a thing with the government with Arrowed House of BSA for 17, and we accepted those referrals in. We haven't had any people with volatile substance referred to Arrowed House in a while. That's 17 and above. So we have bush mobs. So our purpose is if someone does come to us and wants to access support, we will always refer them either to Headspace or to ADSA and just provide information to their families as well. We used to have, we was funded a few years ago for a youth program, and it ran for a couple of years and it done quite well. So we only had one case manager in that position and was working with Aboriginal clients. But unfortunately, that program no longer exists.
Right. Oh, thank you. So, do you think the services are adequate in the territory, in all parts of the territory for all of the the individuals who need to access them? Sounds like particularly for young people, that's a challenge. Would it be true for other groups as well?
Yeah, I think it depends as well. Access. Because remote communities, like when you look at Kindle, for example, that's five hours drive away from Alice Springs and other communities. So access, and that is a barrier sometimes if people want to self-refer into our programs. That can be quite a challenge for people trying to access the service. Is it adequate? I think we do, but I think we could, we could be better funded to be able to, because it's remote, it's very hard, trying to recruit the right people to the roles and stuff like that. So there's a lot of time invested in that. And then when you look at places like Tennant Creek, again, that's really hard as well, because they do a wonderful service there, but there's lots of challenges, and it's only Braddo. We're very fortunate in Alice Springs, there's Karpoo and there's DASA, but because we've had that recent flooding, we had to evacuate our clients, and we were at capacity about 18, I think we had clients, evacuate 18 clients and relocate them, and we had to reduce our capacity. So when those sort of things happen, that means less people can come into our service, or we have to stagger them at different times, which that makes it quite challenging as well, which could put people in prison a bit longer if they're on parole. and things like that, because I know CAPI will also, they have a waiting list, we have a little bit of a waiting list, and now that this other challenge that's presented DASA, with reducing our capacity, yeah, it's something that's been quite challenging for us.
Sure. So we hear often that it's really difficult to access the staff that people need, and obviously with the population who are coming to your service, you want staff who are, who are culturally, able to deal with cultural sensitivities and the like. How do you go with recruiting Indigenous members of the community are you able to provide support with training and things like that for members of the community, or are you able to give us some insight into your, I'm assuming you have challenges with your staffing, are you able to give us some insight into that?
Yeah, look, when I first started, like I said, when I first started DASA in 2012, there was only 4 Aboriginal employees, and that was because of the Aboriginal Outreach Program. And then we increased ours up to about 36%, which was fantastic. We've lost a couple of Indigenous employees. That's something we always try to encourage. We've developed a cultural advisory group as well. That's just something that's happened. And that's just to ensure that our Indigenous employees come on and well supported, and we provide cultural training and stuff like that. But we always, one thing I think DASA prides ourselves on, and we've been fortunate, is we have excellent relationships with training organisations, and they're able to offer training for our staff that need that.
Great. Thank you very much. Thanks, Chair.
Thank you so much.
Thank you so much for appearing for our community today. I understand you deliver drug and alcohol withdrawal programs, and I was wondering if you could tell us if you're facing any challenges in providing those services and what support you might need to do that.
Yeah, so we deliver in collaboration with ASCA, which is the Alcohol and Drug Counselling Service, the low acuity withdrawal program. So they assess through ASCA, and ASCA assess whether they are suitable to come into our program. We were only funded for 2 beds, and because the challenge that we're having right now, because we had to evacuate from our site, the Jacaranda house site, where we had 2 beds, we've had to reduce it down to 1, and because the site where we're operating currently at the moment, we're not allowed to take women, so that's been something that's impacted us as well. But we've been, working closely with our funders and trying to source what our other options will be.
Thank you. No further questions.
Thanks. We've been given a lot of information from a variety of groups from all around the country about alcohol supply. Now, I really realise that can be quite a fraught issue, particularly in remote communities. And I'm just asking for your opinion, but do you think we should be doing more on restricting alcohol supply?
Yes, I think in some ways, yes. And my personal opinion is we know that there's private sales, and when people are going private sales, for example, a bottle of wine would cost you $10. If you go to a liquor shop to buy it, private sales will cost someone maybe $150 or more, depending. And then you look at bottles. So I think, with the remote communities, when they used to have those bans in place where, and some communities still have it where you can't have alcohol in the community, that was from a community perspective.
Yep.
I think that's great because that's for community voices. In town, it's hard to manage that because if people can't access alcohol, I'm not sure if you're aware, but we had an issue with hand sanitizer. And so we were seeing people presenting to us, bringing up shelter, that were drinking hand sanitizer because it was easier to get alcohol that way than it was to go to a bottle shop.
Right. So that was.
So they were turning to other avenues and vanilla essence and other things like that.
Right. So.
Which causes another issue.
Yeah. Okay. And do you think that there is a change in the way people are abusing alcohol and amphetamines, etc.? Are people using other drugs if they can't get alcohol? Is that?
Oh, absolutely. If they can't get alcohol, they'll either get whatever's easily available to them, and that's why I think we've seen that increase in methamphetamines. What we've seen in the last couple of years and what we're seeing from our statistics, our stats, what I can say is that people are going straight from injecting the methamphetamines drug than smoking it.
Wow.
So the youngest that we've heard was a 12-year-old girl injecting.
So you're seeing more people injecting?
Yeah, that's what we're starting to see.
Right. Okay. Are you seeing an increase in overdose episodes, or
No.
what about things like hepatitis B, hepatitis C, HIV? Is that becoming an issue?
Not so much a big issue. We've had a couple clients who have come through our service that have had Hep C and things like that. And we manage and support them. We've had people who come through our sobering up shelter who we knew was HIV positive. So it was just really around educating the staff and yeah, our staff are pretty good. And we also have an excellent relationship with NTARC. So NTARC actually come through to our sobering up shelter once a month, and they actually do that testing, Hep C testing.
Great, thank you.
Yeah.
All right, any further questions? No. Good, well thank you for giving evidence to us today. It's been great. And if you've been asked to take anything on notice, it would be great if you could deliver that to the Secretariat by the 1st of May. And thank you once again for giving evidence, and keep up the good work. So thank you very much.
Thank you so much.
Thank you.
Thank you. Lovely to meet you all. Bye.
Great. Bye.
Bye.
Now, I would now like to call witnesses from the Central Australian Aboriginal Congress to give evidence. That is...
Hi.
Hi, how are you?
Good, thank you. Myself and Dr. John Boffa are online from Congress.
Great, thank you. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
I'm Ebony Abbott McCormack, and I am the chair of Central Australian Aboriginal Congress.
Good. And John, are you online?
Yeah, I'm online. Can you hear me and see me? Yeah.
Here. Welcome.
Okay, I'm Dr. John Boffa. I'm the Chief Medical Officer of Public Health at Central Australian Aboriginal Congress and currently the interim CEO.
Great. Well, I've got to go through the formalities, so thank you for coming today. For the Hansard record, although the committee, can you please state your names before answering any questions? Although the committee doesn't require you to give evidence under oath, I should advise you that the hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false misleading evidence is a serious matter and may be regarded as contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I would like to invite one of you to make a brief opening statement before we proceed to discussion. Would one of you like to do that?
Yes, I will. Thank you.
Good. Please go ahead. State your name first.
My name is Ebony Abbott McCormack, and I'm the chair of Central Australian Aboriginal Congress.
Thank you.
Good afternoon, committee members. Thank you for inviting us to appear at this public hearing. I'm an Aranda woman born and raised in Bantua, Alice Springs, from where I'm speaking to you today. As I've stated, I'm the chairperson of Central Australian Aboriginal Congress, and I am accompanied online by Dr. John Boffa, our interim CEO and Chief Medical Officer of Public Health. Established more than 50 years ago, Congress is a large Aboriginal community-controlled health service delivering primary health care to more than 17,000 people living across the Central Australian region. Throughout our long history, we have always been a strong advocate for addressing the harms that alcohol and other drugs cause in our diverse Aboriginal communities. For us, alcohol is by far the most harmful substance, both in terms of its direct health effects and in the social disruption and violence that it brings. In the colonial situation, alcohol is a dangerous drug, both for its consumer and for those around them. Analysis carried out by the Menzies School of Health Research for Congress shows that in 2020, hospitalisations for our people due to alcohol were approximately 20 times the national average. We are particularly concerned about the association between the unregulated supply of alcohol to our communities and family violence. This remains a serious concern for Congress and for our community. However, we also have a positive story to tell about how sensible regulation of alcohol can reduce those harms. Let me take you back a few years to 2022. A range of the Stronger Futures dry area provisions in the Northern Territory were due to expire in July of that year. Congress warned the Northern Territory government that the expiry of those restrictions would lead to significant increases in alcohol-related harms, but unfortunately those warnings fell on deaf ears. When the Stronger Futures provisions did expire, we saw an exponential increase in alcohol-related harm, much of it suffered by Aboriginal women and children. We saw serious social disorder and national and international media attention on our town. Fortunately, following a visit to Central Australia by the Prime Minister and senior federal ministers on 25th of January 2023, the then Northern Territory Chief Minister announced the reintroduction of dry areas or interim alcohol protected areas known as IAPAs. In addition, alcohol supply was further regulated in Alice Springs, including 2 days a week when takeaway alcohol was not available for sale. The effect was immediate and dramatic, as anyone who lives in this town will tell you. We can back up our lived experience with high quality data based on publicly available data sets that allows us to track and assess the impact of these policy and legislative changes. I refer you to the graphs we have provided for the information of committee members. Following the January 2023 regulations, alcohol consumption as measured by wholesale sales fell by a quarter, or 26% to be precise. Official police crime statistics show that alcohol-related domestic violence fell by 43%. Alcohol-related presentations at the Alice Springs Hospital Emergency Department fell by a quarter, or 25%. A number of academic reviews have documented these improvements in detail. These are dramatic changes which undoubtedly have saved lives. They cost nothing. In fact, they save government and the community millions of dollars in healthcare, policing and other costs. I would strongly urge the committee to recommend that similar evidence-based regulations on the supply of alcohol are adopted wherever alcohol-related harms are a significant concern. However, I do want to leave committee members with a warning. The IAPAs, the dry areas, introduced in 2023, are once again set to expire in February 2027. If these provisions are allowed to expire, we will see the same explosion of alcohol-related harms that we saw in 2022. We are once again urging the Northern Territory Government to act to prevent history repeating itself. I would respectfully ask the committee to urgently add their voices and call for the maintenance of these dry area restrictions. Thank you for your attention. Dr. Boffer and I would now be happy to answer any questions you may have.
Great. Thank you very much, Monique. Would you like to...
I want not to start with.
Sam?
Yeah, I've just got a question on that, around the Northern Territory Government and these this dry area situation sort of expiring and then the government of the day having to do something about it. Is there an argument for a more permanent solution rather than have these sort of interim issues that are set to expire, or maybe not permanent forever, but a longer period?
Do you want me to answer that, Ebony?
Please, Dr. Boffer.
Yeah, look, I think there is an argument for a more permanent solution, and certainly the current Health Minister, Minister Enigen, has suggested a solution that would work. It's got to go through Cabinet, it's got to be approved, but the solution will be to make, instead of having alcohol protected areas, which are an entity that were established under Commonwealth legislation, to convert all the current alcohol protected areas to general restricted areas, or GRAs, which are entities that exist under the Northern Territory Liquor Act. The problem at the moment is a GRA requires evidence of community support to be enacted, and across remote Central Australia, that's how remote Central Australia became dry over many, many years. They've always been general restricted areas. But there are areas, including most importantly the town camps around Alice Springs, Tennant Creek and Katherine, that are not GRAs, although some of them have become GRAs, particularly around Tennant Creek, but in Alice none of them are. So the proposal is to amend the Northern Territory Liquor Act to make the GRAs able to be decided upon by the government of the day, and then that would require a change determined by the government of the day. So that would be long term, but with the capacity to remove them should the situation arise. You know, and we keep saying if we get education right, and we're talking about 27% of Aboriginal children in remote communities participating 4 or more days a week, so we're a long way from getting education right. If we get education right, employment, poverty, income, these housing, these sorts of things, then over a period of time we could start to unwind alcohol regulation, but we're talking a generation at least before that's going to happen. So we need these, we don't want this situation where every few years we're facing a tsunami of alcohol-related violence again, and so we really hope that this time we do see a change that removes that risk that every few years this is up for renewal.
But that is the current Northern Territory government's sort of policy to work through that and pass it through their cabinet if they can do it.
Absolutely, that's where it is at the moment. It's up to them entirely to do that, and you know, yeah.
Okay.
So.
And you're supportive of that?
We're very supportive of that. We understand the argument that used to be put that, you know, people have got to make these decisions for themselves, but alcohol is no ordinary commodity, and as our chair has just pointed out, it causes harm to others, especially women and children, and government have responsibility to keep the community safe and to stop the sort of social crisis that unfolded in the latter months of 2022, which is outlined in the graphs we provided at the end, where you can just see how much the violence increased and the ED presentations increased when Stronger Futures was withdrawn.
Thank you very much. Thank you, Chair.
Alice?
Thanks so much for appearing before our committee today. Your submission makes a recommendation around Centrelink payments and potentially a change of when those payments fall. Would you mind expanding on that for the committee around how that might work in communities like yours?
Yeah, well, look, the evidence base for this goes back a long way. So this was first done in Tennant Creek in a trial that commenced with what was known as Thirsty Thursday. So the Tennant Creek community back in 1995 declared one day takeaway free, and on that day, all Centrelink payments became available. And the rationale was that if the money became available on a day when takeaway alcohol couldn't be bought, a lot more of the money would be spent on food and on essential items for families. And that's what happened. It worked. So although the alcohol restrictions in Alice, we have two now. We have 2 takeaway free days. I mean, if you go back 30 years, everyone would have said that's just impossible. Well, it's happened. And the town not only hasn't the town fallen apart, it's a much better place to live and work, and it's a much better place for tourism. But in spite of those 2 takeaway free days being really effective, there's still the option for people to move their Centrelink payments later in the week, and I understand that's happened to a large extent. So if the Centrelink payments all occurred on the Monday, you would have almost 48 hours where there's no takeaway alcohol accessible, except through one outlet, which is a significant loophole which we want government to shut. It's called the Brewery in Alice Springs, and it's allowed to sell takeaway alcohol 7 days a week to anyone, and that's an anomaly. It's only one outlet though. But other than that, we've got 2 complete takeaway free days a week. And if Centrelink payments were linked to one of those days, it would add further to the reduction in harm based on previous evidence. We've been told that that's not possible from the Commonwealth Government. They can't do that, partly apparently because of a technical issue. I'm not sure what that is, because I thought the payments were all electronic now. And some of these payments go in very late at night or early in the mornings. And so, that would still be a very useful addition to what we've got already.
I'm sure that's something that Tanya Plibersek would be interested in.
Yeah, we've raised it with the Commonwealth Government twice in writing from Congress, with the Prime Minister. I'm not sure that we've directly raised it with Tanya Plibersek, but we have formally raised it with the and we've got response in writing saying it's not possible.
We'll write as a committee to her as well.
That's a great idea.
So we'll see if we can advocate for that as well directly with the Minister.
Thank you.
Good.
Thank you.
Thank you for appearing today. We appreciate it. I just have a question. We heard from another witness that there's been a rise in methamphetamine use. Can you give us any information about the services available to treat that and whether you've seen that on the ground, and any information you can give us around that?
Yeah, look, I'm glad you asked me about this. I did hear that in evidence and it concerned me greatly. I chair the Alcohol, Drugs and Mental Health Working Group under the Central Australian Regional Health Executive Committee, which is a collaborative planning group which includes the senior executives from Alice Springs Hospital, the Aboriginal Health Services, the Northern Territory Primary Healthcare Network and others. And as chair of that group, 2 meetings ago we discussed this issue of methamphetamine use, and we have no evidence to support an increase, but we did say we've got to get better data collect systems. So we do know, because from time to time we hear this reported, that it's gone up a lot. And, you know, we ring police and police are saying, no, they don't have any evidence that there's been an increase. But different groups at different times say there's been an increase. The first point I really want to make, even if there has been a small increase or an increase in methamphetamine use, its use pales in comparison in terms of harm compared to alcohol.
Yeah.
So we're talking a magnitude different level issue, and the sort of people who use methamphetamine up to now have been cashed up tradies. You need money.
Right.
It's $120 a point in Alice Springs, thanks to the very good work the police have been doing to close down local labs. When they come, they get found out, they get closed. So really it's imported, it's very expensive. And at that price, it'll never become a population-wide problem, but it'll become a significant problem for a smaller group of people in the community with money. And that's where it's been. There's no evidence that it's extending beyond that sort of level of use. But we need to keep an eye on it, obviously, and we need better data systems to really be able to understand. But in talking to the service providers who attend that group, there's no evidence from service providers that they've seen an increase, but we need to look at that and get better data. So that's what I'd say about methamphetamine, and the same applies to IV drug use. There's been an increase. There is some evidence that there's been a slight increase in IV drug use in terms of the needle exchange program and how many needles they're giving out. We're absolutely on top of Hep C now because of its revolutionary treatment, which has really virtually got rid of it. So you can't really use Hep C rates as a great indicator anymore. So there are ways we can look as well at the prevalence of IV drug use, and we need to do that better than we are at the moment. But there's no cause for alarm in those areas. The cause for alarm is still, and always has been, alcohol.
Okay, thank you for that. Thanks for the clarification.
Monique, do you want to?
Yeah, can I just ask one question? Could you give us an update, please, on the status of minimum unit pricing for alcohol in the Territory at this point?
Yes, well look, I'll draw the committee's attention to the very last graph on alcohol-induced deaths, graph 5. Can you see that without me sharing it?
Yeah, I can.
Okay, so the big research study that Congress was part of, called the LEARN study, was led by Deakin University, Professor Peter Miller, but it included Menzies, La Trobe, Congress, a whole range of researchers, has produced a report, and this is probably the strongest evidence in the report of the effectiveness of the floor price. So the floor price began October 1, 2018. Look at what happened to alcohol-induced deaths across the Northern Territory and how we're trending down towards the national average. Now, unfortunately and tragically, since 2022, government has stopped publishing this data. So we do not have it anymore. And the reason given was that once it drops below 10, which is that 7.2 data point, it becomes unreliable. The trend is not unreliable. You've got to be careful about individual data points, and it'd be really important that we see this data going forward because the floor price has now been withdrawn. And I would predict that alcohol-induced deaths will now go up again because that is the best evidence I think we had of the effectiveness of the floor price. But government decided it's no panacea. It doesn't get rid of all alcohol-related problems, but it absolutely contributes at the heaviest end of drinking, which is why alcohol-induced death is a good way to look at the impact of removing access to cheap alcohol. Now, although the government have got rid of it territory-wide, in Alice Springs, through the Alice Springs Liquor Accord, all the retailers had decided to keep it at $1.30, a standard drink. Now, the other problem with the floor price, it started at $1.30, it was meant to be indexed for CPI, and it became less effective because it was never indexed. Even though it was legislated that it should be indexed, it never happened. So by the time it was removed last year, it should have been up towards $1.70 based on CPI, and it wasn't. So it was becoming less effective, but in spite of that, retailers in Alice Springs have agreed to $1.30 floor price as a voluntary accord, and they're sticking with it, except for Coles and Woolworths. They won't join the accord, but they're implementing a floor price at around $1, $1.10. They won't say what the figure is, but we monitor the outlets. It is about that level, but unfortunately, when they discount wine and they give 2 bottles for one, the wine becomes about 50 or 60 cents a standard drink, and that's when it's really harmful. Now, we're yet to see the impact of that on alcohol sales, because if you look at the graph we provided on sales, which is really important, which is graph 2, the wholesales graph data, graph 2, that only goes up. Unfortunately, we haven't got that data beyond the June quarter last year. We've only got it to the end of June, and Coles and Woolworths didn't start selling the cheaper wine, the discounts, till that next quarter. So we're yet to see whether what Coles and Woolworths are doing has started to undermine the local accord. It probably hasn't, based on discussions we've had directly with Coles and Woolworths, but we want to see the data. But really, Alice Springs has been protected and buffered from the removal of the floor price due to the voluntary accord. That's not the case in Darwin. It's not the case in Channon Creek. It's not the case in Katherine. And we need to absolutely evaluate. We've got to have access to the data and the tools to evaluate what happens now the floor price has been withdrawn.
Right.
Because sometimes the best way to see the impact is not only to study what happened when it was in place, but to study what happens after a sudden withdrawal. And so that's where we are now. We need to study the impact of its withdrawal. Importantly, Congress has been successful with Deakin, Peter Miller. We've received $1.6 million in MRFF funding to evaluate the impact of the alcohol restrictions that Ebony has talked about in Alice Springs properly, because we've only evaluated, the data we're giving you is publicly available data. It's not sufficient. We really need to know the alcohol attributable hospitalisations. We need to know the ICU admissions, because to quantify the enormity of the impact that we've had with these 2 takeaway free days and the reduction in trading hours, we need to do it properly and thoroughly, because this is in some ways, this is a natural experiment that hasn't happened anywhere else in the country. And it's going to be very significant in terms of reduction in harm, and we need to cost that out properly.
Yeah, I think that's particularly true. I mean, we've been talking in this committee about the need to look at our taxation treatment of alcohol across the board nationally, looking at things like removal of the wine equalisation tax and potentially introduction of a wholesale sort of volumetric tax on alcohol, and the information that you've got locally would be really informative in developing evidence for whether or not that's something we should be doing. Thank you.
Good. Yeah, no, thanks very much, John. Is there any appetite for a Northern Territory-wide pilot program to look at more consistent alcohol restrictions?
That's a good question. I think, I don't think there's much appetite, although if you look at the harms in Katherine, and Channon Creek's got some restrictions but not the same. So I think if you look at Katherine and Channon Creek at a regional level, and the harm in those places we should absolutely be looking, the 2 takeaway free days are clearly a very effective intervention, and they have been well accepted by the Alice Springs community. There's no letters to the paper, there's no people ringing up the ABC saying their lives have been ruined, and that's what used to happen years ago. Any suggestion of a takeaway free day and you'd have all hell break loose, and groups would be coming out saying, you know, life wouldn't be meaningful anymore. So that's not happening in Alice Springs. It's well accepted. People get that it's made a significant difference. And so looking at extending it further, and not just in the Territory, you know, there's places like Broome, and there's places, other regional towns.
Kununurra, I know, yeah.
Yeah, absolutely. It's like we said in the submission, it costs nothing, saves lives, and it could be seen as a circuit breaker for a generation or two, because we should address the underlying determinants of demand, have to be addressed as well, but they take a long time to address. And as an immediate and temporary fix, it's a bit like Opal Unleaded. When Opal Unleaded came in 2007, the naysayers said, this won't work. How do you expect to treat such a complex problem like petrol sniffing amongst young people with a simplistic solution like Opal Unleaded? Well, prior to Opal Unleaded, there are about 4 deaths a year, and there are 450 petrol sniffers across Central Australia, many of them damaging their brains, and many of them who lived ended up with brain damage in nursing homes. Since Opal Unleaded, there's been 1 death since 2007. So you can die. If you sniff opal fuel for 15 minutes or more, it's still very toxic, but people don't sniff it because it's not, you don't get the high.
Yeah.
But there's been 1 death and there's no brain damage. So Opal Unleaded really did demonstrate the effectiveness of supply reduction. And we've also shown in alcohol policy, it makes a big difference.
Yeah. Is there any correlation, and this goes back to a previous inquiry, any correlation between alcohol intake in the Territory and diabetes diabetes complications that you're aware of?
Yes, you can look at, when we look at hospital admission data, we do a thing called alcohol attributable fractions. For all major diseases, it's been worked out what proportion for cancers, what proportion of cancers attributed to alcohol consumption. Clearly, bowel cancer, breast cancer are partly caused by alcohol. Same with obesity. Obesity is partly caused by alcohol consumption, and therefore you can correlate what proportion of diabetes and obesity is due to heavy alcohol consumption. So that's done when we look at alcohol attributable admission rates and alcohol attributable causation.
Good. And the last issue I just want to explore, is there any data about alcohol consumption in the Territory and harm to children, either physical harm or things like fetal alcohol syndrome or alcohol abuse during pregnancy?
Yes, so the LEARN study did look at this. They looked at this to some extent. We've personally at Congress, we've got now good data on because we've got a service that's able to assess neurodevelopmental disorders in children. So it can accurately diagnose FASD, autism, and all of the different types of disorders that can occur. So we've got, we've got data on the numbers of children that actually have FASD in Central Australia now. It won't be the full extent of the problem, but it shows, if I looked at, last time I looked at it, was about 146 diagnosed children with FASD. It could be probably higher now. I could look while I'm talking to you, but so we are able to, but it's not publicly available. Like, I think there's very little publicly available about FASD, and without the assessment service I'm talking about is what you need to diagnose it. So that's a service that includes paediatric neuropsychologists, speech pathologists, occupational therapists, and a paediatrician and Aboriginal staff. They provide comprehensive assessments and they diagnose it properly. They don't over-diagnose, which is another risk if you do this badly.
Sure.
So that service has meant we've been able to find FASD is very significant. So is just the more significant problem in early child is what's called chronic understimulation of children. So if parents are drinking and gambling to a certain extent. It's not that there's overt neglect occurring in their households, but the children might just be put in front of the television. They don't get read to. They don't get into any sort of routine. Sure. Their sleep gets disrupted. They don't get fed well enough. These things absolutely impact on the brain development of children, and that has never been properly quantified. I don't think, not in our context or nationally. There are reports that look into this and talk about, that it is a significant issue, and it is clearly a significant problem, but it's part of alcohol-related harm. When you see the reports on quantifying alcohol-related harm, this stuff's ignored. The police collect very good data they collect very good data on children exposed to violence and alcohol in the home, and that can be looked at. We've looked at that through the LEARN study, and it shows just how prevalent, unfortunately, for so many children, they are exposed to alcohol-related violence in early childhood, and that in itself causes stress and is a negative impact on healthy brain development. So and if you look at the AEDC scores, that's Australian Early Development Census, that's the thing that checks children in the first year of primary school. The number of children in Central Australia and across the Territory and in other disadvantaged parts of the country that are below normal on 2 or more domains, and it's often the cognitive and language domain and the emotional self-control domain, is extraordinarily high. It's more than 5 times the national average. So that is a sign. All these things added up tell us that early childhood is a very significant period in which harm from alcohol consumption from parents is really impacting on the next generation.
Yeah, and that has huge effects on productivity and... Yeah.
Can I ask one more question?
Sure. Yeah, of course.
Just on the 2 graphs that you referred us to, which is the hospitalisations and the deaths from alcohol in different parts of the Northern Territory. Firstly, obviously there's a trend going down and down and down towards 2022. Firstly, would you expect that trend, even though the data's not available, anecdotally, would you expect that trend has continued or spiked and then gone down again? And furthermore, do you know why the data from 2022 is not available?
So on the first point, I think that I would expect that trend hasn't continued once the floor price was withdrawn, particularly in Darwin. Alice is protected, but Alice is only a small proportion of the Territory population. This is territory-wide data.
Yep.
So Darwin's the place that's felt the full brunt of not having floor price, and I would expect that has had an impact on alcohol-induced mortality. So I would expect that has started to go back up again at a territory-wide level. The reason the data is not available at the moment, there's been a commitment to restore the data, but it hasn't happened yet. But the reason it was taken down is because of a concern that once you get below, because of the population size of the Territory, once you get below around 10 deaths per 100,000 or thereabouts, it becomes uncertain as to the accuracy of that data point. And so it was taken down because of that. But it was taken down at a time when they didn't think the floor price was going to be removed. So now the floor price is removed and it's likely going back up again. It's really important we see it. If it stays down around 7.2, 6, 5, 8, you've got to look at it thinking it could be anywhere within a range of error that's quite large. But the trend is what's important.
Yeah.
And if that's now trending up again, we need to know that.
Absolutely. Thank you.
Good. Well, look, thank you so much for your attendance today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 1st of May 2026. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request any corrections to transcription errors. I'll also note, for your interest, we will be writing to the Minister for Social Services about your suggestion that Centrelink payments be linked to takeaway free days in in Alice Springs, Catherine and Tennant Creek.
Yeah. Well, across the Northern Territory, if not everywhere outside Darwin, if it's not compatible in a capital city.
All right, well, we will make that correspondence to the Minister and let you know her response.
Yeah, look, and just before we finish, there's a couple of things we haven't talked about that I think are important. The Northern Territory Liquor Commission recently proposed some really important changes which would value add. One is that the Liquor Act be amended, the condition of licensing be such that licensees are held responsible for alcohol-related crimes that are committed immediately on people leaving their venues. This has happened in South Australia. The Liquor Act's been amended like that. This makes an enormous difference to the responsible service of alcohol. If you have that provision, and it could be in the Liquor Act. It's called the Dram Shop Liability Act in America. It's existed in 50 states in America for a very long time. And it says to licensees, if you serve people to the point of significant intoxication, they leave your premise and stab someone or assault someone or hang themselves, you will be held accountable partly for that. You're not taking away individual responsibility, but in addition to individual responsibility, you're saying to licensees, you've got a responsibility. So that was one thing. The second thing was applying the BDR on licence. At the moment, the Banned Drinkers Register, which is effective, there's been a big evaluation of that. It's an effective tool. The new government has increased the number of people on the register. It's gone up to about 5,500. But people on the register who can't buy takeaway alcohol can easily go on licence and get served, because you can't, unless you have an electronic scanning system on entrance, photo ID on entrance, you don't know whether the people who are drinking on licence are on the BDR or not. It's time to include the BDR on licence. That was another one of the Licensing Commission recommendations. And the third thing, which is less significant, was light beer only before 3 o'clock. That's happened and it's working, it's effective. The other thing that you should be aware of, the current proposed changes to the Northern Territory Liquor Act are very much going to weaken the power of the Liquor Licensing Commission and give a lot more power to the Director General of Licensing. And this is very much not what the Riley Review recommended. Trevor Riley, who's a former head of the Supreme Court, was very clear about the separation of powers between the role of the Licensing Commission, which is to assess all new applications for licences and to allow to apply the public interest test, to allow objections from community groups for any new licence application. If these changes go through, low-risk licences will be able to be approved without any ability to go through that public hearing process or to apply the public interest test. Yep. We're really concerned about that because in the category of low-risk licence, they've included social clubs. Now, social clubs don't exist in most remote communities. At the moment, if a remote community wanted to set up an Aboriginal social club, they would have to apply to the Licensing Commission and they'd have to address a lot of issues. They'd need to address, limits on takeaway. They'd need to ensure there are police in the community. They need to ensure there's responsible management for the club. They need to limit the amount of drinks that people can buy at any one time. There's lots of things that are required by the Licensing Commission. If the Director General of Licensing was allowed to approve those applications, there's no guarantee that any of those safety measures would be applied for social clubs. Yep. Breweries are considered low-risk licences. The brewery in Alice Springs is very much a high-risk licence now and is behaving in what I would consider to be a rogue way and selling alcohol when we have the takeaway free days and selling alcohol to people who are on the BDR because they don't do photo scanning, so they don't know. Anyone that comes there could be from a remote community, they could be on the BDR, they still are able to buy takeaway alcohol. Now, breweries are considered low risk in these changes. So they're deregulating and promoting, it's all about promoting small business. We understand the importance of small business, sure. But alcohol is no ordinary commodity. When it comes to selling alcohol, there's good reason why the Liquor Act has required the Licensing Commission to be involved in any decision about who gets to hold and operate a liquor licence. And that's going to change with these changes.
Good.
So they're a major concern, those changes.
Well, we'll certainly take that on board. although we have limited ways of changing what the Northern Territory government wants to legislate for. But we'll certainly take on board what you've said. So thank you for appearing today.
Thank you.
And you'll be sent a transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. And thanks once again for all your efforts.
Thank you.
No worries. Thank you.
Thank you.
Very helpful.
Good. So just for the community's benefit, we will write that letter to the Minister for Social Security. Social Services, sorry. Good. I'd now like to call representatives of the Association of Alcohol and Other Drug Agencies Northern Territory to give evidence today. Hello.
Hello, how are you? Good afternoon, and thank you for the opportunity to speak today.
Good. Thank you for talking to us. Now, I believe we have Mrs. Stephanie Holmes.
Yes, that's me.
And Ms. Jennifer Somerville.
Yes, that's me.
Good. Now, I've just got to go through the formalities. For the Hansard record, could you please both state your full names and the capacity in which you appear before the committee? We'll start with Mrs. Holmes.
Hi, I'm Stephanie Jane Holmes, and I'm the Executive Officer for the peak body for drug and alcohol, Northern Territory.
Good. And then Ms. Somerville.
I'm Dr. Jenny Somerville. I'm the Capacity Building and Engagement Coordinator for the Association of Alcohol and Other Drugs Agencies in the Northern Territory.
Great. Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. Giving a false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite one of you to make a brief opening statement before we proceed to discussion.
Beautiful, thank you. That will be me.
Go ahead.
Thank you. Good afternoon, and again, thank you for the opportunity to speak today. As I said, my name's Stephanie Holmes, and I'm the Executive Officer for the Association of Alcohol and Other Drug Agencies Northern Territory. The acronym for us is ARDENT, and that's the peak body for drug and alcohol treatment services across the Northern Territory. ARDENT is a member-driven not-for-profit organisation, and we work to strengthen a culturally diverse and sustainable AOD sector. And I'd also like to acknowledge the traditional owners on the lands on which we live, work, and pay our respects to elders past, present, emerging, and for Jen and I, this is Larrakia country today. At the onset, I want to emphasise a simple but critical reality that alcohol and other drug harms are complex, and simplistic punitive responses don't always work. Services can support meaningful change for a period, but no service, no matter how well resourced or how well intended, can change the environment a person returns to. And for many people we work with, that environment is one that makes recovery extraordinarily difficult to sustain. When I was reflecting on this, taking any remote community in the Northern Territory, when someone completes treatment and returns to community, they are often returning to a house built for a standard Australian nuclear family, not for the kinship family structures that define our First Nations life. Overcrowding is not an exception, it is the norm, and houses are consistently occupied beyond their intended capacity, not because families are doing anything wrong, but because those houses were never designed with their reality in mind. Layered onto this is the weight of the social determinants. The cost of living is punishing for all Australians right now, but for First Nations people in remote communities, the gap between economic reality and a viable, stable life is not a gap, it's a chasm. Entrenched unemployment, limited economic pathways, and the daily grind of getting by in a system that was not built for you does not reflect your world. When someone returns to overcrowding, poverty and community, where getting ahead feels structurally impossible, the risk of returning to AOD use is not a personal fouling. It is a predictable response to an unlivable set of circumstances. And this is the question that sits at the heart of everything we do. How do we ask people to picture flourishing when flourishing sometimes is genuinely hard to see from where you're sitting? This is not a question services alone can answer. It's a question about policy. It's a question about investment and about whether governments are willing to address the conditions that drive harms, not just the harm itself. Sorry. These often ignore underlying social and economical and psychological drivers of harm. Worse, they increase stigma, discourage people from seeking help, and ultimately lead to poorer outcomes for individuals and families and communities, which in turn increases widening the gap. What is needed in the Northern Territory and across Australia is a public health approach grounded in evidence and human rights. That means treating AOD use as a health issue, and where punitive responses do not serve to reduce harm, they only serve to exacerbate the poverty and marginalisation that creates the harm in the first place. Stigma itself is harm. It disempowers people and it encourages blame and makes help seeking and recovery harder. If we can prioritise harm reduction, demand reduction and supply reduction initiatives as opposed to punishing users of AOD use, this is a start and is imperative. Embedding lived and living experience and First Nations community leadership and ensuring people can access support without fear of judgment is extremely important, but in the Northern Territory context, First Nations people accessing support in ways which acknowledge family structures. In the NT, the need for reform is critical. We continue to see the highest per capita alcohol consumption in the country, highest rates of risky drinking and illicit drug use, and alcohol contributing to 2 2/3 of family and domestic violence incidences, and increased rates of alcohol-related assaults and hospitalisations, which I'm sure Dr. Boffa has covered. Members describe these harms as playing out in everyday life through family violence, social pressure on people trying to stay sober, and young people growing up around alcohol and other drugs, offending behaviours and instability as normalised realities. That the Northern Territory and our communities are entrenched in poverty with the highest levels of unemployment, the highest levels of suicide per capita, the highest levels of domestic and family violence, and the highest First Nation rates of incarceration across our country. Core values are no different for any Australians. Like, everyone wants to feel the flourish and well-being of our children, our young people, our elders, and the community as a whole, as a nation. But as a whole, what we're seeing is that First Nations people are also wrestling with extreme poverty. An example of this is that community food is often too expensive to purchase, including fresh fruit and vegetables. The cost of fuel to get to support, often power and electricity running out as the top-up cards can't be purchased. And the further remote you go in the Northern Territory, the harder and truer this story becomes. At the same time, our services are often under so much pressure. Wait lists stretch up to 6 weeks. Workforce and skills shortages are so significant, and many people present with alcohol and other drugs and mental health challenges, including criminal justice and housing and homelessness. As one of our frontline workers said, a psychiatric appointment, drug or alcohol episode might be happening on the day in the community, not in 2 weeks, not in 6 weeks, whenever the bed is available. The gap between need and access is where harm escalates. People often leave treatment, custody or structured support and go straight back to the same environment with either no or low aftercare support, transition or continuity, and also to overcrowding. Our submission sets out 10 recommendations, and today I'll highlight the key priorities. For us, we need a coordinated long-term strategy. The Northern Territory currently lacks a full funded up-to-date alcohol action plan and a comprehensive drug strategy. Without this, efforts are fragmented and inconsistent. At service level, fragmentation shows up in inconsistent referral pathways, gaps between treatment, gaps in aftercare, and a lack of sustained support across the points where people are most likely to fall through these gaps. We are calling for a renewed NT alcohol action plan with funded commitments, a long-term anti-drug strategy aligned with the national framework embedding the principles of harm minimisation, and a meaningful inclusion of lived and living experience and First Nations leadership. Secondly, we must fund accessibility, culturally safe treatment services. Treatment works and is highly cost effective. We understand that every dollar invested in AOD treatment returns significant savings across health, justice, housing and social systems, but access remains a major barrier. Equity of access is not just about whether a service exists on paper, it's also about whether a person can access an option that is psychologically safe, gender safe, culturally safe and therapeutically appropriate. Many members have raised cases where women, including women leaving custody, face very limited and confusing rehabilitation pathways and do not have a clear option that feels safe and workable. For those women who are primary caregivers of their elders or children and young people in their families, there's no treatment programs that can take children, young people and elders that could have caring responsibilities. What we need to think about is how can women caring for young people attend programs and as still the primary caregiver, because funded programs to support these types of care models are not existent. People face long wait times, costly associated with residential treatment, poorly maintained facilities, and limited integration between services. We need sustained index funding that supports community-based services, residential rehabilitations, infrastructure and workforce capacity, and integrated no wrong door models of care. Thirdly, we must invest in the workforce. A strong system depends on a skilled and supported workforce. For many of our members, the workforce issue is not only vacancies, it's a turnover, a loss of continuity, a loss of relationship, difficulty retaining people in remote and high stress roles, and the reality that trust is repeatedly broken when workers do not stay long enough to build these relationships. Members often emphasise that importance of valued living and living experience and relational capability alongside formal qualifications. What we know is that we have many CEOs, many executives and many managers who are often required to work shifts within their own services due to such severe and significant workforce shortages that this is more apparent the further remote you go within the Northern Territory.
Yeah. We are short on time. I might get you, if you can maybe just email the 10 priorities to the committee. We might open it up for questions.
Yeah, perfect, no problem.
Good. I'll just start by a few logistical questions. We've been really hearing a lot about access to alcohol and restricting access to alcohol. Do you have an overall view on that in the Northern Territory, or whether we should be looking at ways to restrict access?
Yeah, I do. Punitive measures like restricting alcohol use is only one aspect. It's about also supply reduction measures as well, because they absolutely have a role, but for Ardent, we support a well-designed evidence-based restriction. It's not about arguing against them, but for us, it's about restrictions alone are not sufficient. What we know is that evidence from NT's own history bears that out. We've had, various forms of alcohol control in the Territory for so long. Obviously, the floor price, licensing restrictions, and now the banned drinkers register. And whilst some have, shown, and I'm sure John covered this, positive effects, particularly around acute harm reduction, none of them have actually resolved that underlying problems on their own. And the reason isn't really straightforward, because if we restrict supply without addressing demand, then without treatment services and without addressing housing, poverty, trauma, and community-led responses, people find other ways that harm shifts rather than reduces. And for me, what I see in our communities is that most of the vulnerable people are often the ones least well served by broad controls. So I would be saying what we're calling for is a comprehensive approach, that restrictions are part of a broader strategy and they really take a place, not as a substitute for another one. And what that means, I guess, is that restrictions working alongside properly funded treatment and harm reduction services like our member supports, that this genuinely is a good investment into the social conditions that drive problematic, use in the first place. And I think the other thing is that any restrictions need to be designed with community in mind, not imposed on them. The NT has a long history of top-down alcohol policies that have not always reflected the realities of the communities in which, they're meant to serve. And I think genuine engagement for First Nations leadership in the design process and a proper evaluation of what works and what doesn't is how we get it right.
Mm-hmm. Okay.
Jen, is there anything you want to add to that?
No, I think well said, Steph, that we can't look at simple restrictions as the only answer. Yes, we know that, for example, if you increase the number of takeaway licences or takeaway alcohol outlets in any community, alcohol consumption on the whole does rise. There's evidence around that. So yes, certainly restricting and taking a really measured approach around issuing liquor licences is a really important aspect of what we need to think about as a society, and I think Dr. Boffa probably would have gone into that in more detail, but definitely that needs to be balanced with demand reduction and harm reduction strategies.
Yeah.
And that's about people being able to access treatment, supports, whatever they need at any given pathway in the journey to address their own alcohol use if that's the issue, but also to address the range of problems that feed into that, the overcrowded housing, the family violence, all of these problems stack onto each other.
Yep.
So it's not as simple as just restricting supply.
No, I don't think anyone's suggesting that.
Yep.
And what I'm hearing also is that any form of rehabilitation needs to basically include the families.
Yeah.
Is that right? And so that
Yeah.
women can take their kids and the families can be involved in supporting the rehabilitation.
Yeah, that's true. What we know is that that's one of the most important and consistently raised issue from our members. And, our treatment system was largely designed around individual models of care and still is today. One person, one bed, one program. But what we know is that a model doesn't reflect the reality of First Nations community and family structures and those kind of kinship obligations. So, if we could include the family, and we do have some treatment services, but also we've got member services that do alternatives to custody. And that's really good because for First Nations people, and particularly women and, vulnerable women escaping violence, is really hard to, bring children. It's not just simply leaving your children in the community. It's about, making it culturally unsafe for her to return, which again is really deeply distressing. That this is more about, making sure that if women are the primary caregivers or the family structure, that, residential rehab needs to be funded to accommodate the whole family structure, and that, funding models that allow family members to be part of that treatment journey and not excluded from it is first. Secondly, programs designed around kinship structures, not kind of that nuclear family assumption, and community-based on-country options that keep people connected to place and family while accessing support are different ways that we need to start thinking about around offering, flexible but culturally safe models that recognise healing.
And non-residential rehabilitation.
And non-residential. It's not always residential. So often, looking at healing as a collective, not just, as an individual, and not just in a therapeutic residential setting, that it's,
Good.
Where communities look at
Great.
safety and community-led treatment.
Yeah, thanks.
I have one.
Sure.
Yeah, thank you so much for appearing today. We appreciate it. I just have one. Could you give us a bit more detail on your the Strong Born campaign and the impacts that has had across the territory for FASD?
Yeah. I can. I am actually one of the directors on the No FASD committee, and I also have a middle child with fetal alcohol syndrome, who was my kinship sister's daughter, so I understand a lot about it. What we know is that, you know, the NT carries, similar to the Cape and also the Kimberley, a disproportionate burden of that harm. What we know is that, you know, that the campaign's really strong around evidence-based and non-stigmatising, and the messages around no shame or blame are really good, and particularly for First Nations women who we know are already navigating, significant social pressures and systemic barriers. What we know is that it's being delivered through trusted community channels, that, you know, if it's not just government communications, and that communities, not necessarily trust. What we need to do is be more sustainable over time, that it shouldn't just be a one-off campaign, but a longer-term, properly resourced effort, which is embedded into our communities across health messaging, education in schools, and also the child and family member services and community services. And one of the things that we really want to do with this campaign is include it into workforce training, and that's where health workers, teachers, justice workers, AOD staff, housing staff can support to identify concerns around FASD right on the inception of it, because what we know is it's not just behaviourally that we, can put program and structure support, but there's also the other things around how do we get more diagnostic pathways within the territory, within the Kimberley, to be able to get the diagnosis early, but also those diagnostic services, because at the moment what we're seeing is they're grossly inadequate. I think, we know that it's massively underdiagnosed within the Northern Territory, and I think, also the overrepresentation of people with FASD in the justice system is not just a coincidence. We know that that's happening at the moment. So, what we're seeing is that lowering the criminal age of responsibility is actually putting more younger people with undiagnosed FASD into the judicial system, and that it's a great program, but there's things that we need to be doing better with it.
Okay, thank you. Thanks for that.
Alice.
Thank you so much for your contribution to our inquiry today. Ms. Holmes, you sort of mentioned that recovery is often difficult to sustain, and obviously there's no doubt about the risk of relapse can be very high if those support services aren't in place sort of in that recovery phase. And you sort of mentioned the importance of that wraparound support. And I was wondering what's one recommendation you'd make to our committee to allow for better support in that recovery stage?
Yeah,
that's a really good question.
I think from our member point of view, the aftercare in the Northern Territory is very limited. And when what happens is, because all of our rehabilitations are based in the regional centres, and the person returns to a community that may be 2,000 kilometres to the west. So sustaining that aftercare pathway for any individual is extremely challenging. Rehabilitation services aren't necessarily funded to do it, while there are other services that provide primary health care and social emotional wellbeing, potentially on certain communities. Those programs are the funding for those is quite scattered. So, where those services exist and whether they exist on any given community is very much based around that. So that challenge around sustaining that relationship after someone returns back to community is ever present.
Yeah, and I think also on top of what Jen said, on recovery being difficult to sustain, I often say to people in services, and being a Wodji woman from the East Coast myself, is that recovery is not a moment, it's a process. you know, it's rarely linear. So, you know, it's about where do we meet people where they're at? It's about getting people into treatment, but we talk far less about what happens after that. And the gap between the end of treatment and the beginning of a sustained life in recovery is where we're losing people. You know, it's really hard to maintain that when you're going back into the same situation. I think on the risk of relapse and what it actually means is that relapse is not, is not evidence that treatment failed. It's not evidence that the person failed. It's about how do we do re-engagement after leaving treatment early or after a relapse that we can still have a positive outcome. So it's about building people up to understand what relapse actually means and what wraparound support services where there may look to be insufficient of what we can actually offer. So if we stigmatise relapse, then, you know, if we treat it as the end of the story rather than the point of a journey, we make it harder for people to come back from that. And I think lastly, you know, the importance of wraparound support is not a luxury add-on. It's an infrastructure of recovery. It means that if housing is stable and someone can return to a safe house, if it means continuity of a worker who knows you and your story, it means, you know, for me, connection to mental health support, it means connection to primary care, it means connection to family and services and cultural support, that it's not separated or siloed services that don't talk to each other. It's about an integrated system with a single point of coordination. Because for First Nations people, in the NT, wraparound support must also be culturally grounded. So it's about thinking about how do we acknowledge family obligations, kinship responsibilities, but also to include that on-country connection where it's meaningful and it's long-term healing and recovery, and, you know, providing that support, you know, within the services, not, you know, when one leaves that we close the file.
Thank you, that's really helpful. No questions?
Sam?
I have no questions.
No
Thank
question.
you, Chair.
Good. All right, well, thank you very much for your attendance here today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 1st of May 2026. You'll be sent a copy of the transcript of your evidence and we'll have an opportunity to request any corrections, transcription errors. And once again, thanks so much for appearing today.
Thank you so much. Take care.
Good. Good. So, I would now like to call representatives from the AP Wylands Substance Misuse Service, Mr. Mark Thompson, Director, Aboriginal Clinical Services and Strategy.
Hi everyone.
Hello, how are you?
Good, thank you.
Good, thanks for appearing today. I've just got to go through the formalities. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
My name is Mark Thompson, and I'm the Director of Aboriginal Clinical Services and Strategy with Drug and Alcohol Services South Australia.
Good. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. Giving a false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement before we proceed to discussion.
Thank you. Thank you for the opportunity to present today, and I acknowledge the committee for undertaking this important inquiry. And I'm currently talking to you from Kaurna Country in South Australia. And as I mentioned before, I'm Mark Thompson, Director of Aboriginal Clinical Services and Strategy. I'm a Southern Aranda and Urabunna man, and I've worked with the health sector for over 25 years, including 16 years specifically focused on alcohol and other drugs, and my experience includes extensive work across the AP Wylands, which we have a mobile assertive outreach program, and also in the Adelaide Metro, where we have the Aboriginal Connection program, which works with people who are either rough sleeping or homeless, either from locations such as the Northern Territory, Western Australia, or remote communities within South Australia. And we also have a mobile AOD van.
Good. Would you like to make an opening statement about what services you offer and what you do?
So my focus today is to provide practical on-ground insights into the health impacts of alcohol and other drugs, particularly for Aboriginal communities, and to outline what is working, where the system is falling short, and the key changes required to improve outcomes. From our experience, alcohol and other drug-related harm is not just a clinical issue, it is closely linked to housing instability, intergenerational trauma, access to culturally safe services, and broader system fragmentation. And throughout the response today, I'll focus on three key areas around health impacts, what is working, system challenges, and recommendations.
Good. And have you seen any recent trends in what you have to be offering?
Sorry?
Are you seeing any recent trends, any changes in what's happening to the clients you're serving?
Yeah, so what we're actually seeing is when people are transitioning from remote communities, they're at higher risk of engaging with intravenous drug use. So we're seeing for people that are 40 and under, we're seeing higher rates of methamphetamine use. And with people that are 40 and above or 41 and above, we're still seeing people with primary issues of concern around alcohol, cannabis, and tobacco. What we're also seeing is people are staying longer periods of time, either in regional or city locations. So previously we would see people come down from remote communities and they would stay anywhere from 4 to 6 weeks. Now we're seeing people stay on and off longer periods of time, up to 12 months at a time, which increases the level of concerns for them for being targeted by people that may want to sell drugs to them as well.
Yeah. Why are they coming to the cities?
Well, that's a range of reasons. A big reason for that is not being able to afford to live in communities. Communities can be very expensive to live in now. Even with our staff that go up there, they say that, the affordability for people is so high now that people will move to other locations and will stay with other family members, creating vulnerable tenancies because the costs are a lot cheaper, say in regional areas or a place like Adelaide, for example.
Right. Good.
Some of the other reasons that people are moving is to look for better opportunities for work and, education for their kids as well.
Right. Okay. Would anyone like to ask any questions?
Yes. Thank you for appearing today for us. We really appreciate it. Something I haven't heard as much about is specific treatment programs for increases in meth use for under 40s. Can you talk to the very specific services and gaps in terms of providing support for those people specifically?
Yeah, so one of the things that we have introduced is bringing services to people, because what we find is a lot of people that are coming from remote communities don't know how to navigate the system as well. And this was something that we identified quite a lot during one of our iterations of a supervised alcohol provision program. And what it identified is that when people come down, you know, they may know of a service here or there, but in the confines of utilising the whole system, people aren't aware of how to get there, you know, how to make the appointments, those sort of things, just having that knowledge base. And so what we did through the Safety and Wellbeing Task Force that was established here in South Australia is that we put in a joint budget bid to receive a mobile alcohol and other drugs van, which is dedicated to drug and alcohol. So what we do with that van is we take that out with an addiction medicine specialist, and as we're seeing people, so this is one of the ways that we engage, and I can send you photos of the van as well. So it's a culturally appropriate van where we start off the conversations not just specifically around drug and alcohol, but a primary healthcare approach as well that leads into conversations about drug and alcohol. And so any individuals who are seeking syringes from our needle and syringe program, we'll have a conversation with them about what it is that they're using, how to dispose of the syringes safely, do they need any other support? And because we have the addiction medicine specialist there on site with us, we're able to fast track referrals into our withdrawal services unit at Glenside campus. And because we also have another assertive outreach program which works with people that are rough sleeping and homeless, we also provide that service in terms of being able to follow up with people on the days when the van's not there. So we'll continually have ongoing conversations to work with people around that. And so through the process of ongoing engagement and building that trust and rapport, then people will then be more likely to want to look at, you know, how can they get a better, you know, get a service in terms of, you know, wanting to reduce any type of, you know, whether it's meth use or whether it's cannabis or alcohol.
Thank you.
Thank you so much for appearing before our committee today. It's great to have you here. It sounds like the APY lands are very large and very remote. How do you navigate accessing these remote communities? Because no doubt there are, you know, telecommunications issues you'd be finding, so online services might be, you know, a bit trickier. How do you go with navigating, you know, trying to actually get to these remote communities so you can help them?
So what we have is a fly-in, fly-out service. So we currently spend 2 weeks every fortnight in the APY land. So we do a hub and spoke model. So we're based in Armada, that's where our houses are. And from there, then we will outreach to the other major communities within the APY lands.
Great, thank you.
Good. Sam, have you got any questions?
Yeah, I understand. So the APY lands, the communities there are prohibited with alcohol, is that correct?
That's correct.
So, so the nature of what's causing the main issues is obviously alcohol coming in illegally, or people going outside and consuming alcohol and obviously coming back. What's your view of how the prohibition has worked, firstly, and secondly, you know, what threatens that? What threatens the success that you're having at the moment?
So with the alcohol, as you mentioned, a lot of our referrals come from issues of concern that have happened off community. A lot of people that are involved with any type of sly grogging don't bring it into the community. It's always just outside of the community at locations that the police would know of. And so then that creates a few issues. So it's more the eastern communities have closer access to alcohol than the central and western communities. we see a lot less volatility around alcohol consumption there. And in terms of, you know, whether this type of model works, you know, I look at Wadair, after 30 years of being a dry community, they've now opened up and established a social club where people can drink 6 mid-strength beers a day. And I think that's probably where we should be heading. As recently, we've done 2 iterations of what we called a supervised alcohol provision program. And I'm happy to send you the evaluations of those, where we did a qualitative, quantitative and an economic analysis of the supervised alcohol program. And this was based on the model that in Mount Isa, Jamalia Topsy-Harry, which I visited back in 2015 while the Northern Territory intervention was still happening. And what I noticed, because I'm a Western Desert Aboriginal person from Alice Springs myself, and what I noticed when we did the site visit to Mount Isa was that probably at least 50% to 60% of the people that were engaged in that program were Western Desert people. And one of the upsides of that total program, which is a homelessness to housing program that has a range of services engaging in there, where people have got to, you know, to be a part of the program, they've got to, you know, take on some type of training. They learn about daily active living skills, and so, and you know, and they're in there for there's no like 6-month or you know 3-month program. It's basically when the person's ready to leave that service. And one of the strengths of that program that I identified straight away was one of the managers took a phone call from a real estate agent looking for one of the participants to rent someone's property, not a housing trust or social housing, but someone's actual property, investment property, I would say. And to me, that really spoke about the strength of that program, that people that are coming from that context who are homeless are able to be considered for this type of approach. So through the Safety and Wellbeing Task Force, DASA did 2 iterations. One was during COVID, and then there was another one that we did that was a voluntary program. And what we identified in that was 80% of the participants were women. So it really demonstrates that it's not safe for women to be rough sleeping, you know, with other groups of people that are drinking alcohol. And, you know, and it also gave people that opportunity to wake up without a foggy head, you know, after, because here at our Sobering Up unit in South Australia, in Adelaide here, when people do their BAL, the blood alcohol level, you know, they're generally blowing, you know, up to 0.4 blood alcohol level, and can be drinking up to 4 litres of cask wine throughout the day. So it really shows high levels of alcohol intoxication. Whereas if we could be establishing a supervised alcohol program for a long-term use to change the binge drinking behaviour that unfortunately has been going on for approximately 237 years now, because, you know, Aboriginal people primarily are drinking outdoors, so they come to the attention of police who will decant the alcohol, and then you'll see it in the Northern Territory in Alice Springs now, there might be a drinking circle in the Todd River, and then you'll see the NT police driving up there, and you'll see everyone consuming their alcohol as fast as they can before it gets tipped out. And you'll see the same thing here in Adelaide, in the Adelaide Parklands, when SAPOL's coming around. Was there another part to your question that I haven't?
You did. I wasn't aware of that situation. Is it Wadair?
Yeah.
If I mean, timing's everything, and you'd be the judge of this. But if in some APY lands that are currently dry, prohibited, but there are some problems with people going out to border areas and consuming in a non-controlled way, if that was moved into that situation, a social club where people drink, I think you said 6 mid-strength beers in a session, do you think that works and it changes people's relationship with alcohol, doesn't eliminate it and therefore create a temptation to go and binge, but changes people's relationship with alcohol?
I think over time, once people get to a certain level of understanding that, you don't have to consume alcohol at the levels that you do, and that you can be satiated with, having a drink, but not getting, intoxicated to the point where it's becoming a problem.
Yeah.
I think people will see that, but then there's other things you need to include in that as well. In terms of one of the key things we identified was that having, if we could have a situation where, people are able to engage in maybe some type of social enterprise program where they're able to do work, meaningful work, not just work where it's, like some of the work for the dole type of programs where, people are doing work that isn't really meaningful, but something that's meaningful to people, so that they know that they, that they need to be getting up every day to be able to fill out those core responsibilities that they have for themselves, the community and their families. So you probably, just that on its own wouldn't work on its own. It would need to factor in social enterprise, make sure people are getting upskilled to be able to take on certain roles, those sort of things. And I reflect on the remote area employment services program where APY is one of those CDP regions. It would be good if, with the funding that's coming in there, if we could think outside the box and look at different opportunities, because a lot of the things we're doing are just pure straight Western models that don't really align to Aboriginal people and, what they need for culture, So one of the things I'm even trying to implement on the APY lands at the moment is to have a Anangu casual employment pool where all the fly in, fly out services, each community they go to can then tap into, a core group of Anangu that might be able to, that have been cleared, for their police checks, all those sort of things, so that they can come and work and experience what it is like to work with an organisation like DASA, or, for CAMS, which is a child adolescent mental health service, and other services that may be working across the APY land. So it gives people an idea about, social determinants of health for themselves that they can make articulated responses to, in terms of, I might want to work with DASA a bit more, or I might want to work with this other service based on, what it is that that fulfills their social determinants.
Yeah.
Thank you. That's great, Mark. Thanks for that.
Yeah, just a couple of things to clear that up. You seem to be saying that if you have social stability, then prohibition is not the answer. Is that the take-home message?
Yeah, I believe so. I believe that if people had the opportunity to be able to be productive in their community, recognised for that, and having a drink here and there, but I think that would certainly help make a lot of change. It might reduce the amount of people that are coming out from the communities as well, because we know there's a small core group of people who do leave the communities to go and, drink. Yeah. But the majority of people that do leave the communities aren't doing that. They're looking for other better opportunities to improve themselves and their family. Good.
All right. So thank you very much for your attendance today. If you've been asked to provide any additional information, would you please forward it to the Secretariat by the 1st of May 2026. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request corrections to any transcription errors. Once again, thank you very much for appearing today.
Thank you.
No worries. Thank you.
Thanks. All right, now we will now adjourn until our meeting at the site visit at Cyrenian House at 2:30. Good. So we're now adjourned.